Two separate samples viridans streptococci equals S aureus equals S galolyticus equals Hasek group major equals community acquired enterococci without a primary focus copyright persistently positive cultures with microorganisms consistent with endocarditis equals 22 positive blood cultures drawn 12 hours apart equals allo 3 or a majority of 4 separate blood cultures dash copyright 1 positive culture for Coxiella burnetii or an antiphase 1 IgG titer of equals 1:800 asterisk ch istic ecdiographic finding of IE new. Valvular regurgitation. Scent predisposing condition, example underlying heart abnormality, for drug use, Ca. 23, fever 38 degrees Celsius 100.4 degrees Fahrenheit minor asterisk vascular abnormalities 1 asterisk immunologic phenomena microbiology, positive blood cultures not fulfilling major criteria or serological evidence of infection with common organisms. Microorganisms demonstrated by tissue culture or histology of pathological by characteristic histologic features of active endocarditis. Diagnostic category definite i.e. if any of the following are present, 2 major criteria 21 major criterion plus 3 minor criteria 25 minor criteria 21 pathological criterion possible i.e. if any of the following are present, 21 major criterion plus 1 minor criterion 23 minor criteria. Laboratory studies, 15. Routine studies. Scent CBC, leukocytosis with left shift. V. Back collapse fine text outline. Laboratory studies, 15. Routine studies. Scent CBC, leukocytosis with left shift plus inflammatory markers, TCRP. TTESR, 121st, asterisk urinalysis, to assess for hematuria and nephritic sediment, 2, 51L24. Blood cultures 125. See also intravascular catheter-related bloodstream infections and bacteremia. Scent sampling protocol copyright prior to treatment, 3 sets from different venipuncture sites copyright monitoring, 2 sets every 24 to 48 hours until clearance scent interpretation copyright positive bacterial cultures, assess according to the modified Duke criteria. O-negative bacterial cultures do not rule out endocarditis. Patients with endocarditis may have a negative result due to L2625 equals antibiotic therapy prior to blood culture sampling equals fastidious bacteria, most commonly Coxiella burnetii and Bartonella species. Echocardiography, 5. Transthoracic echocardiography, TTE, is the initial test of choice for all patients with suspected IE. Transesophageal echocardiography, T, is more invasive and is added in select cases. Scent indications for T include, copyright presence of high-risk features OTTE findings inconclusive or suggestive of IE copyright concern for intracardiac complications, example abscess, plus echocardiographic findings fulfilling Duke criteria for IE, similar in TTE and T, registered LL271I28. Copyright valvular vegetations, hyperechoic mobile masses located on the valve, mural endocardium or prosthetic material 29 copyright abscess, example paravalvular abscess, new valvular regurgitation, especially with valve prolapse, perforation or destruction, copyright prosthetic valve dehiscence. 6. T is more sensitive, 90%, than TTE, 75%, and is more reliable in ruling out IE in patients with moderate to high pretest probability. WA. CE. Pathology. Acute disease, leading to valve insufficiency, septic embolic infarcts, tendinous cord rupture, 31 copyright erosion equals fibrin deposits on valves O ulceration copyright perforation. Asterisk chronic disease, leading to valve insufficiency and valve stenosis, 31E erosion reorganization of fibrin layer copyright granulation tissue valve scarring / fibrosis copyright calcification thickened and / or shortened tendinous cords. Equals, A. Differential diagnoses. Non-infective endocarditis, non-bacterial thrombotic endocarditis, 22133. Scent description: rare, non-infective form of endocarditis due to sterile platelet thrombus formation on the heart valves, usually mitral and aortic valves. O. Liebman-Sachs endocarditis, a type of non-infective endocarditis with varicose vegetations in individuals with systemic lupus erythematosus or antiphospholipid syndrome. 52. Scent etiology: copyright malignancy, example pancreatic adenocarcinoma. O. Hypercoagulable states. OE underlying trauma, example from indwelling vascular catheters. O. Previous rheumatic fever. Copyright autoimmune conditions, example systemic lupus erythematosus, rheumatoid arthritis, antiphospholipid syndrome. 34. Copyright chronic infections, example TB, pneumonia, osteomyelitis. Scent clinical features: copyright valves and cardiac function are rarely impaired. Compared to i.e., vegetations are easily dislodged and embolization is common, leading to hemorrhages under the nails, skin, and retina. Most affected individuals are asymptomatic until embolization occurs. Scent diagnostics: O. Negative blood cultures. Copyright echocardiography, valve vegetations. Copyright biopsy, definitive diagnosis, equals sterile vegetations on either surface of the valve composed of immune complexes, mononuclear cells, and thrombi interwoven with fibrin strands. Not always feasible, therefore diagnosis is mostly made based on clinical findings, negative blood cultures, echocardiography findings, and no response to antibiotic treatment. Scent treatment: copyright anticoagulation with heparin. Copyright treatment of the underlying condition. Other intravascular catheter infection. Scent infection of prosthetic implants, example prosthetic valves, joints, cardiac electronic devices. Scent prosthetic valve thrombosis. Hematogenous osteomyelitis. Scent septic thrombophlebitis. The differential diagnoses listed here are not exhaustive. CE. Management. Initial management, 15L351I36. Scent unstable patients, use the ABCDE approach and initiate management of sepsis as needed. Scent consults. Copyright consult infectious disease, ID, early to plan treatment and consider empiric therapy. Copyright identify patients with indications for surgery. Consult in IE. Scent antibiotic therapy. Copyright start empiric antibiotic therapy for IE once blood cultures have been sampled. LLL3 Scent L. Copyright switch to targeted antibiotic therapy for IE once blood culture results are available. 1L3 Scent L. Scent supportive care, treat urgent complications, example AHF, heart block, and the underlying cause, example removal of infected central lines. If IE is suspected, first obtain blood cultures, then consult ID to plan empiric antibiotic therapy. When culture results are available, adapt the therapy accordingly. HECE. Treatment. Antibiotics. Scent choice of empiric agent, consult infectious diseases and take into account patient and disease factors as well as local and individual flora and resistance patterns. See risk factors for IE and classification. Scent common empiric antibiotic regimens, equals, A. Treatment. Antibiotics. Scent choice of empiric agent, consult infectious diseases and take into account patient and disease factors as well as local and individual flora and resistance patterns. See risk factors for IE and classification. Scent common empiric antibiotic regimens, O. Native valve endocarditis, vancomycin plus a beta-lactam, example ceftriaxone, cefepime. AO prosthetic valve endocarditis, add gentamicin plus rifampin to vancomycin plus a beta-lactam, if. Scent common targeted antibiotic regimens. Copyright Staphylococci 1-methicillin susceptible staphylococci, MSSA anti-staphylococcal beta-lactam, example nafcillin, oxacillin, A. Methicillin resistant staphylococci, MRSA vancomycin prosthetic valve endocarditis. Scent indications for surgery consult in IE include, copyright prosthetic valve endocarditis, copyright valve dysfunction leading to heart failure, copyright uncontrolled infection, example enlarging vegetation, persistent bacteremia o paravalvular extension or complications, example abscess, pseudoaneurysm, fistula, heart block, copyright fungal endocarditis e high embolic risk, example mobile vegetation 10 mm, recurrent embolism, scent surgical options, valve replacement or valve repair, see treatment in valvular heart diseases. OS. OROA. Prevention. Endocarditis prophylaxis, 43114441I451I35. Prophylaxis is indicated prior to certain procedures with a high risk of bacteremia in patients with high-risk cardiac features. 43. Scent cardiac risk factors requiring IE prophylaxis, for procedures that may cause bacteremia, a copyright presence of prosthetic cardiac valve or material, copyright history of endocarditis, copyright certain types of congenital heart disease, CHD, example unrepaired cyanotic CHD, repaired CHD, within 6 months of repair, repaired CHD with residual post-operative shunt or regurgitation, 45,135. Procedures requiring IE prophylaxis in patients at risk for IE, copyright some dental procedures including tooth extraction and routine dental cleaning, copyright any invasive procedure involving infected tissue, example abscess drainage, copyright placement of a CIED 461L40, copyright surgical placement of prosthetic cardiac or intravascular material, example heart valve, intravascular graft, 46 cent common regimens, usually administered 30 to 60 minutes prior to the procedure, 35 copyright prior to dental procedures, 43 equals no penicillin allergy, amoxicillin or ampicillin or cefazolin, penicillin allergy, a macrolide, example azithromycin or doxycycline, 1 copyright prior to CIED placement, cefazolin. Copyright IE prophylaxis is not routinely recommended prior to non-dental procedures, including respiratory, skin, musculoskeletal, gastrointestinal, and genitourinary procedures, unless infected tissue is present. 35. OES. Tips and links. Sources equals A. C. Infective endocarditis, 1/1. Bacterial colonization. Endocarditis. Infective endocarditis VV, coronal section of the heart, frontal view, there is bacterial colonization on the mitral valve. Copyright emboss. Infective endocarditis, peripheral embolic and immunologic phenomena, cardiac heart murmur, mitral regurgitation, aortic regurgitation, heart failure, arrhythmias. Roth spots. Lee UWWI, for ////glomerulonephritis. Constitutional occult fever, chills, malaise, Osler nodes, night sweats. Copyright dyspnea. Copyright tachycardia. G at arthritis, Janeway lesions, Kurjalis. Clinical features of infective endocarditis VV. Copyright emboss. Splinter hemorrhages in endocarditis. The vertical hemorrhages, arrowheads, underneath this patient's fingernails are most commonly caused by trauma but can also occur as a result of immune complex deposition or microthrombosis in subacute, infective endocarditis, SLE, or rheumatoid arthritis. Source: Splinter hemorrhage, Splarka, Wikimedia Commons licensed under public domain. Infective endocarditis, 3/5. Janeway lesions VV. Multiple erythematous macules are visible on the thenar eminence and the base of the thumb. These Janeway lesions are typically caused by septic microembolism secondary to infective endocarditis. Source: Janeway lesion by Warfieldian, Wikimedia Commons, licensed under CC by SA 4.0. Infective endocarditis, 4/5. EERRR underscore, EE, A, RIS Fe. Osler nodes VV. There are multiple raised nodular lesions on the palm and palmar aspects of the first and second digits. The lesions appear dark brown, indicating subcutaneous hemorrhages. This is the typical appearance of Osler nodes. Source: Osler nodules, hand by Roberto J. Galindo, Wikimedia Commons, licensed under CC by SA 4.0. Copyright. Overlay. Roth spots. Fundus photography of a left eye. There are multiple red, white-centered lesions, which reflect small retinal hemorrhages with central accumulation of leukocytes or fibrin thrombocyte emboli, examples indicated by arrowheads. Although these findings were formerly considered to be associated almost exclusively with infective endocarditis, they may actually occur in a variety of conditions, including hypertensive, diabetic, and HIV-related retinopathy, leukemia, and intracranial hemorrhage. Circle, optic disc, M equals macula source, figure 1 in, ocular manifestations of endocarditis by MD Chimawaythek, Intech Open, licensed under CC by 3.0. And infective endocarditis, 1/4. Overlay. Bacterial endocarditis of the mitral valve. Echocardiography, transesophageal, mid-esophageal two-chamber view, an irregularly shaped vegetation, red overlay, is seen on the mitral valve, green overlay. LA, left atrium, LV, left ventricle source, figure 1, in, infective endocarditis manifesting as severe elevation in serum aminotransferases in the absence of severe tricuspid regurgitation, heart failure, or shock, a diagnostic challenge by Amaradun Gaie, Hager J.A., Kamau J., Ernst E.B., Kalinkel M., Snyder R., Curious, licensed under CC by 4.0. Modifications: image was cropped, letter A in the top left corner was removed, FXV, red arrow removed. Overlay. Aortic valve vegetation. Echocardiography, transesophageal, mid-esophageal long axis view, a vegetation, red arrow, is seen as an echogenic structure on the right coronary cusp, green overlay, of the aortic valve. A. Aorta, LA, left atrium, LV, left ventricle, RV, right ventricle source, figure 1, in, infective endocarditis manifesting as severe elevation in serum aminotransferases in the absence of severe tricuspid regurgitation, heart failure, or shock, a diagnostic challenge by Amaradun Gaie, Hager J.A., Kamau J., Ernst E.B., Kalinkel M., Snyder R., Curious, licensed under CC by 4.0. Modifications: image was cropped, letter B in the top left corner and letter V were removed. And infective endocarditis, 3/4. EEFE, Pat T, 37.0 C www43/min TT, 39.0 C. Paravalvular abscess of aortic valve VV. A 60-year-old woman with increasing shortness of breath, fever, and chest discomfort following aortic valve replacement. The mid-esophageal aortic valve short axis view demonstrates paravalvular thickening and irregularity, arrowhead, and a mobile hyperechoic mass arising from the aortic valve, arrow. These findings are consistent with infective endocarditis associated with a paravalvular abscess of a prosthetic aortic valve. Source: Fig 2, in, Case Report, Takotsubo Syndrome in Infectious Endocarditis by Ratka M., Gundlach J., Rotbauer W., K. Edler M., Springer Link, licensed under CC by 4.0. L. Portable Supine 1230 HRS. Overlay. Septic pulmonary emboli VV. X-ray chest, supine, of a 24-year-old patient with history of intravenous drug use and septic emboli. Numerous pulmonary nodules are present in both lungs, examples indicated by green overlay. Some nodules have lucent centers indicating cavitation, examples indicated by red overlay. Airspace opacities, which were better appreciated on a subsequent CT scan, not shown, obscure the margins of some nodules. The cardiac silhouette appears prominent as a result of rotation of the patient to the left. The differential diagnosis of causes of multiple cavitary lung nodules includes bacterial, tuberculous, fungal, and parasitic infections as well as several non-infectious causes, example rheumatic diseases and malignancies. Arrowheads, thoracic spine spinous processes, dashed lines, medial clavicles, yellow overlay, right central line source, Fig 2, in, daptomycin failure for treatment of pulmonary septic emboli in native tricuspid and mitral valve methicillin resistant. Staphylococcus aureus endocarditis by Zina A, Zervos M, Stefan W. ETAL, Hindawi, licensed under CC by 3.0. Modifications, image cropped. L portable supine 1230 HRS. Overlay. Septic pulmonary emboli VV. X-ray chest, supine, of a 24-year-old patient with history of intravenous drug use and septic emboli. Numerous pulmonary nodules are present in both lungs, examples indicated by green overlay. Some nodules have lucent centers indicating cavitation, examples indicated by red overlay. Airspace opacities, which were better appreciated on a subsequent CT scan, not shown, obscure the margins of some nodules. The cardiac silhouette appears prominent as a result of rotation of the patient to the left. The differential diagnosis of causes of multiple cavitary lung nodules includes bacterial, tuberculous, fungal, and parasitic infections as well as several non-infectious causes, example rheumatic diseases and malignancies. Arrowheads, thoracic spine spinous processes, dashed lines, medial clavicles, yellow overlay, right central line source, Fig 2, in, daptomycin failure for treatment of pulmonary septic emboli in native tricuspid and mitral valve methicillin resistant. Staphylococcus aureus endocarditis by Zina A, Zervos M, Stefan W. ETAL, Hindawi, licensed under CC by 3.0. Modifications, image cropped. Infective endocarditis, 1/3. Overlay. Infective endocarditis VV. Photograph of a dissected heart specimen opened to show the endocardial aspect of left atrium and ventricle. The mitral valve is thickened, indicated by arrow, and shows numerous yellow vegetations on the atrial, superior, aspect of the valve, examples indicated by arrowheads. This gross appearance is typical of infective endocarditis of the mitral valve. Source, ID #851, Centers for Disease Control and Prevention, Centers for Disease Control and Prevention licensed under public domain. Valve thrombosis in recurrent endocarditis of the mitral valve VV. Macroscopic specimen showing the left atrium and the left ventricle. Thrombotic material is visible in the left atrium in the mitral valve region. Source, copyright IMPP. Infective endocarditis of the aortic valve. Click on the microscope icon to view the entire specimen through a virtual microscope. Source, copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, PD Dr. Alberto Perez Buza. Smart Zoom Viewer. Powered by Smart Zoom, copyright 2023 Smart in Media. Smart Zoom Viewer. A. Asterisk. PIDL. Asterisk OBDA. Pi. E registered, RT, OA, A, dash. Z. E. Add AA star. 46 asterisk hashtag asterisk APD. O, O. JX he base of the aortic valve E. Asterisk. The 9J4. 4. Underscore. LL6. Asterisk Fe. J. A. 7. Degree underscore J. 7 number 7. J7 yen A, dash underscore OL asterisk slash J, ID, go slash, asterisk A asterisk. Asterisk tiny, A, 4 slash, J, J. Equals, Y, J tis. 7. D. J4. Asterisk. Asterisk. Bad 5. Powered by Smart Zoom Copyright 2023 Smart in Media. Smart Zoom Viewer. Degree, A. Powered by Smart Zoom Copyright 2023 Smart in Media Copyright 44%. Degree Cent A, Cent A. Smart Zoom Viewer. C asterisk E3 underscore asterisk resegmented nuclear granulocyte X asterisk equals E. A. Degree. MF backslash star. Degree BRQ segmented nuclear granulocytes are histological backslash. Degree 44 JRA3 evidence of a florid inflammation of the tissue I4. E star. NE backslash asterisk E, A. EA registered as, A is CTS yen, far. Tine AE, and we and M84J grit EE registered or. Yen at. 4. At. E. Plus 47 E asterisk AO. Smart Zoom Viewer. L. Eco OE. Add BD equals 502. Dash. R, degree 2 asterisk 4, fill, degree 4. YA. 44E. Asterisk, asterisk AEEN. WCAEMES, asterisk is 2AE. SS tapes OTID, ON. AOET3. Dash underscore underscore. 4 AOEPS. A, 4 equals. 7. Star. 6. Star. I. Equals. 1. 7. XBAS asterisk. The surface of the valve can be destroyed by the inflammation and by the direct action of the bacteria. 4. Underscore EE a flap perforation or demolition can result as a L consequence. 4 kit R. 4A4, slash equals A. Slash T. Is 29. RFJ4A trademark S. G asterisk. 4. Z slash RI slash. Slash. Slash J, 4. 7. IE4J tray. Off BF 98. 2 RATS Pi FD. RAFAEJ, SE powered by Smart Zoom Copyright 2023 Smart in Media, at AE degree, ISD, Pad 4 LLPA, OE4. Smart Zoom Viewer. Asterisk. 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 Underscore. X fibrin coagulum in endocarditis. Yen in the case of bacterial endocarditis, superficial F bacteria containing fibrin form clots, which cause a septic arterial embolism when they detach. A 4V. MT. Degree IG slash. 5, Z. 7. F2. 4 asterisk 7A. 7AA underscore. AA underscore L. Z. 44A, Y. Asterisk E. Powered by Smart Zoom Copyright 2023 Smart in Media equals RE. Smart Zoom Viewer. Bacterial colony in the valve X. 4 in bacterial endocarditis, germs, mostly bacteria and E. fungi, are often directly visible. They form blue flakes that destroy the matrix of the flap. Most commonly seen bacteria are streptococci, staphylococci, and equals star enterococci. Add asterisk e al al dash asterisk al x cardiac arrest and cardiopulmonary resuscitation. Cardiac arrest is the sudden cessation of cardiac function and blood circulation, manifesting as apnea, pulselessness, and loss of consciousness. In adults, cardiac arrest is most commonly caused by cardiac conditions, example coronary artery disease, but it can also have non-cardiac etiologies, example hypothermia, whereas in children, etiologies are more varied and more frequently related to profound hypoxia, example due to airway obstruction. Cardiopulmonary resuscitation, CPR, is a life-saving procedure that artificially maintains circulation and ventilation until cardiac function is hopefully restored. Immediate initiation of high-quality chest compressions is the most important factor for survival after cardiac arrest. There are two clinical algorithms to provide CPR, basic life support, BLS, for lay rescuers and medical professionals alike, and advanced cardiac life support, ACLS. Solely for medical professionals. BLS involves checking responsiveness, calling for help, performing chest compressions and rescue breaths, and, if available, using an automated external defibrillator, AED. ACLS includes additional measures, example resuscitation medications, airway management, and identifying and treating reversible causes of cardiac arrest, example HS and TS. Modifications to BLS and ACLS are required for children and neonates. After the return of spontaneous circulation, ROSC, comprehensive post-resuscitation care is essential for good neurological and functional outcomes. This involves neuroprotective measures, hemodynamic support, critical care admission, monitoring for organ dysfunction, and treatment of underlying causes and complications. VA OFOS Overview. Recommendations in this article are consistent with the 2020 and 2023 American Heart Association, AHA, and the International Liaison Committee on Resuscitation, ILCOR, guidelines and consensus statements. Practice may vary according to regional authorities and resources. Consult local protocols whenever possible. 1112. The initial approach to cardiac arrest is influenced by the rescuers, example number of rescuers, training received, patient factors, example age, pregnancy, and location, i.e., in hospital versus out of hospital. CENT identify cardiac arrest and initiate an emergency response. + begin BLS, i.e., immediate CPR, especially chest compressions. * defibrillate shockable rhythms. CENT transition care to ACLS providers. Initiate post-resuscitation care. Algorithms. Overview of life support algorithms. Key components. CENT activation of emergency response BLS algorithm * high quality CPR automated external defibrillation. High quality CPR equals defibrillation DS ACLS algorithm rhythm recognition in cardiac arrest 2 resuscitation medications treatment of reversible causes of cardiac arrest. Airway management maintenance of hemodynamic and respiratory parameters within target ranges PCI for suspected cardiac causes. Example STEMI temperature control post-resuscitation care management of acute seizures other neuroprotective measures. TE and cardiopulmonary resuscitation, CPR. Approach. CENT for sudden cardiac arrest, use the CAB approach to begin chest compression as soon as possible. 1 chest compressions 2. Airway 3. Breathing CENT prioritize airway and breathing, i.e., ABC approach, for cardiac arrest secondary to respiratory arrest. Asterisk minimize interruptions to CPR. 41 asterisk if the diagnosis of cardiac arrest is uncertain, initiating CPR is preferable to withholding CPR, 1/3. Chest compressions equals 5. A. Back collapse find text outline. 3 chest compressions. Chest compression technique differs in children, infants, and neonates. Key targets for high-quality chest compressions: EO compression rate, 100 to 120 per minute. Copyright compression depth for adults, 5 to 6 centimeters, 2 to 2.5 inches. Copyright allow full chest recoil between compressions. Scent provider positioning and technique, adults and children, excluding infants, kneel or stand next to the patient depending on whether they are on the ground or in a bed, respectively. Center the hands, one on top of the other, fingers interlaced, over the sternum. Keep the arms straight, do not bend the elbows, the shoulders should be directly above the hands. Use full body weight to deliver rapid, firm compressions. Scent patient positioning, supine on a firm surface, minimizing interruptions. Copyright restart CPR between rhythm analysis and shock delivery, while the defibrillator is charging. Resume CPR immediately after shock delivery. Copyright high-quality chest compressions are associated with better survival rates. Rescue breathing degree. Scent mouth-to-mouth 1. Open the airway using the head tilt/chin lift maneuver. 2. Pinch the patient's nose closed. 3. Form a tight seal over the patient's mouth. 4. Breathe slowly into the patient's mouth for 1 second, check for chest rise to confirm sufficient ventilation. 5. Move away from the patient's mouth between breaths to allow air to escape, ensuring the patient's airway remains open. Scent if equipment is available, ventilate with 100% O90 BMV, with or without basic airway adjuncts. Administer 2 breaths after every 30 chest compressions. Continuous compression only CPR is a reasonable alternative to mouth-to-mouth rescue breathing if the provider is uncomfortable administering rescue breaths or there is concern for infectious disease transmission. Basic life support, BLS. The BLS algorithm allows appropriately trained individuals to recognize cardiac arrest, provide high-quality chest compressions, deliver ventilations, and utilize an AED. BLS algorithm, 81111. Scent assess scene safety, example check for fire and other hazards, don PPE for infectious or toxic exposures. Scent assess patient responsiveness, proceed with BLS if no response or only abnormal breathing, example gasping. Asterisk call for help, shout for assistance and / or activate the emergency response. 1. Retrieve an AED or defibrillator, example from the nearest crash cart. Scent assess for signs of life, check pulse and respiration simultaneously. Copyright perform airway opening maneuvers as needed. 1. Copyright look, listen, and feel for air movement. Copyright check for a central pulse for no longer than 10 seconds. If no palpable pulse, apnea, and / or agonal respirations, begin CPR immediately. Copyright if respirations are normal, place the patient in the recovery position before continuing with medical assessment. Perform high-quality CPR. Copyright position patient supine on a hard surface. Maintain appropriate CPR ratio, 30:2 for adults, i.e., 30 chest compressions followed by 2 rescue breaths per cycle. Copyright minimize interruptions to CPR. Scent defibrillate as needed. A. Scent defibrillate as needed. Use an AED or defibrillator as soon as it is available. Copyright perform 5 cycles, 2 minutes, of CPR between each rhythm analysis and / or shock. Plus endpoints. Copyright the patient shows clear signs of life, example coughing, breathing, movement of the extremities. Rescuers are too fatigued to continue. OEACLS trained providers arrive. minimizing the interruption and delays to the initiation of high-quality CPR and early defibrillation of shockable rhythms are the most important factors for survival and reducing long-term complications after cardiac arrest. Copyright for a collapsed patient. Remember the DRS ABCD, check the environment for danger, assess for a response, shout for help, open the airway, check for breathing, start CPR, and attach the defibrillator. IE1, by BS, WAWREE asterisk, ESZO, EAE at equals IAE. Metiata XEWLY. Automated External Defibrillator, AED. Scent description, a portable electronic defibrillator that independently identifies shockable rhythms and delivers a shock, designed to be used by lay rescuers in out-of-hospital settings. FA plus applying pads. 1. Copyright dry the skin where the pads will be applied, if necessary. Anterior lateral placement, place one pad on the right chest, above the nipple, and the other on the left side of the thorax, below the nipple. Copyright anterior posterior placement, place one pad anteriorly on the chest and the other posteriorly on the back. Scent rhythm analysis degree pod during rhythm analysis. 4. Repeat analysis every 2 minutes, 5 cycles of CPR. Asterisk delivering shocks. Copyright the AED will indicate if a shock is advised and may begin to charge. Resume CPR while the AED is charging. Copyright when advised by the AED, clear the surroundings _, then deliver the shock. Resume CPR immediately after shock delivery, perform for 2 minutes, 5 cycles, prior to the next rhythm analysis. XA. Special situations, 121.11.11. Drowning, prioritize ABC approach and rescue breaths, perform CPR prior to calling for help. Foreign body aspiration, FBAC unresponsive patient with suspected FBA for details. Copyright check airway for dislodged foreign body, FB, during 2-minute pulse check and remove if present. Copyright avoid blind finger sweep if FB is not visible. Copyright if CPR unsuccessful, consider emergency airway procedures for FBA. Scent hypothermia requires specialized vital signs assessment. Copyright CPR generally continued until fully revar med, example using ECLSE. Consider mechanical CPR devices. Copyright see hypothermic cardiac arrest for details. ZIOE. Advanced Cardiac Life Support, ACLS. The ACLS algorithm adds the following to the BLS algorithm: rhythm recognition in cardiac arrest, resuscitation medications, treatment of reversible causes of cardiac arrest, and advanced airway management. Maximizing high-quality CPR and early defibrillation remain the most important factors for survival and good neurological outcome. 3. ACLS algorithm, equals 3111. Scent priority 1, CPR. Copyright perform high-quality CPR for at least 2 minutes before the first rhythm check. Copyright avoid interrupting CPR unless it is for rhythm and pulse checks and / or shock delivery. Back collapse. Find text outline. Scent priority 2, rhythm and pulse check. Copyright attach monitors and / or defibrillator pads. Pause CPR for no longer than 10 seconds for rhythm recognition in cardiac arrest. Copyright shockable rhythms, VFib or pulseless VT. Proceed to defibrillation, draw up epinephrine plus either amiodarone or lidocaine. Degree non-shockable rhythms, P or AZ's toll do not defibrillate, draw up epinephrine. Repeat rhythm and pulse check every 2 minutes, resuming CPR in between each check. Scent priority 3, defibrillation of shockable rhythms. Copyright deliver a shock as soon as VFib or pulseless VT is recognized. Resume CPR immediately after shock and continue for 2 minutes until next rhythm and pulse check. Copyright if a second attempt at defibrillation is unsuccessful, administer resuscitation medications. Scent priority 4, resuscitation medications. 2. Copyright obtain peripheral 4/IO access and administer medications without interrupting CPR. Non-shockable rhythms, administer epinephrine as soon as possible, repeat every 3 to 5 minutes as needed. Copyright shockable rhythms. After 2 unsuccessful cycle of defibrillation, administer epinephrine. After 3 unsuccessful cycle of defibrillation, administer amiodarone or lidocaine. Copyright after the first dose of epinephrine, addition of vasopressant methylprednisolone may also be considered. 2. Re-evaluate indications and dosage at each subsequent rhythm and pulse check. Sent priority 5. HS and TSO address these in parallel with CPR, defibrillation, and resuscitation medications. Copyright C. Reversible causes of cardiac arrest for targeted therapies. 6. Evaluate and treat reversible causes of cardiac arrest, example HS and TS, without stopping CPR, defibrillation, or administration of resuscitation medications. Continue CPR and defibrillation attempts as long as the patient has a shockable rhythm. Rhythm recognition in cardiac arrest. Rhythms in cardiac arrest. A rhythm appearance pathophysiology. Coarse or fine irregular waves of varying size, morphology, and rhythm. Arrhythmic and unsynchronized high-frequency contraction of the ventricles result, no cardiac output. Ventricular fibrillation, VF. Shockable rhythms typically rapid, regular broad complexes. MS. Pulseless ventricular tachycardia. Monomorphic VT, polymorphic VT, or Torsades. Pulseless VT, rapid, regular ventricular rate, along with pulselessness, result, insufficient cardiac output due to high heart rate. Points may be present. Variable equals R _cent rhythmic electrical activity, commonly low rate, wide, distorted. QRS may resemble any regular electrical activity on the complexes, without a detectable central pulse. Non-shockable monitor rhythms. Pulseless electrical activity. No electrical activity result, no ventricular mechanical activity, cardiac output, or pulsases. Toll gently undulating line Fa. Registered. Avoid pausing CPR for longer than 10 seconds for rhythm and pulse checks. Defibrillation. Defibrillate as soon as possible once a shockable rhythm is recognized to maximize survival. Procedure. 1. Set the defibrillator to unsynchronized mode. 1. 2. Place the paddles or pads firmly on the patient's thorax. 3. Set energy dosage and press the charge button. Copyright biphasic defibrillator, preferred, 1114. Equals first shock, 120 to 200 J equals additional shocks, 200 to 360 J equals, A. Copyright monophasic defibrillator 1, 360 J for all shocks. 4. Resume CPR while the defibrillator is charging. 5. When fully charged, clear the patient, i.e., ensure no other personnel and equipment are in contact with the patient or pads. 6. Administer the shock. Copyright paddles, simultaneously hold down both shock buttons located under each thumb. Pads, press the shock button on the defibrillator. 7. Resume CPR immediately after defibrillation for a full 2-minute cycle. 1, 3. Ensure the defibrillator is set to unsynchronized mode when treating cardiac arrest with a shockable rhythm. Resuscitation medications, 1L2. Obtain peripheral LV access or O access for medication administration without interrupting CPR. All resuscitation medications should be administered while CPR is ongoing to ensure their circulation to the heart and brain. Sent shockable rhythms. O epinephrine equals first dose, after second unsuccessful defibrillation attempt equals repeat every 3 to 5 minutes. O amiodarone or lidocaine equals first dose, after third unsuccessful defibrillation attempt equals an additional dose of amiodarone or lidocaine can be given after 3 to 5 minutes. Sent non-shockable rhythms, administer epinephrine O first dose, as soon as possible or repeat every 3 to 5 minutes. Any rhythm, after the first dose of epinephrine, addition of vasopressin plus methylprednisolone may be considered. 2. WA 2. Reversible causes of cardiac arrest. Asterisk the HS and TS can be used to help remember the most common reversible causes of cardiac arrest. 14 cent other causes include hypoglycemia, hypocalcemia, hypomagnesemia, anaphylaxis, and asthma. HS and TS, 41 5s HSSTS asterisk hypovolemia tension pneumothorax asterisk hypoxia asterisk tamponade, cardiac, asterisk hyperkalemia / hypokalemia scent toxins asterisk hydrogen ions, acidosis, thrombosis, pulmonary, plus hypothermia thrombosis, coronary. LEOE. Cessation of CPR. Return of spontaneous circulation, ROSC, 141. Scent indications of ROSC copyright clear signs of life, example breathing, coughing, or movement OE return of palpable pulse and blood pressure or presence of arterial waveform with intra-arterial monitoring O an abrupt and sustained increase in expiratory co-measured with capnography management begin post-resuscitation care. Copyright neuroprognostication copyright identify and treat complications of CPR and / or cardiac arrest. Termination of resuscitation, TOR, 3 degrees. No clear guidance exists on when to terminate CPR in hospitals. Decisions should take into account the following factors: scent the patient's wishes, terminate resuscitation efforts if a valid DNR or an advance directive prohibiting resuscitation is discovered. Scent experience of the provider and resuscitation team equals, A. Plus factors associated with poor outcomes, 5 copyright patient factors, older age, poor functional status, terminal malignancy, organ failure copyright resuscitation factors, delay to onset of CPR, delay to defibrillation. OO. OFOS. Post-resuscitation care. The post-ROSC phase of cardiac arrest focuses on optimizing hemodynamic support, identifying and treating the underlying cause of arrest, and minimizing secondary brain injury through neuroprotective measures. Airway, secure the airway, scent target respiratory parameters, scent target hemodynamic parameters, administer 4 fluids as needed and consider vasopressors and / or inotropes. Obtain 12 lead ECG, to elevate for acute ST segment elevation, additional management and urgent interventions, 11L2. Scent address the cause of arrest, see reversible causes of cardiac arrest. Scent identify patients requiring urgent coronary angiography. Diagnose and manage seizures. Neuroprognostication, 11. Scent the extent of irreversible loss of brain function can be estimated clinically, example neurological examination, apnea testing, and using ancillary brain death tests, example EEG. Plus brain death assessment is typically carried out 72 hours after cardiac arrest or cessation of TTM. 1E see also ethical issues concerning brain death. Organ donation, 0LL5I2. Scent consider organ donation for all patients with ROSC in whom brain death is declared. If ROSC does not occur, kidney and liver donation may still be possible, depending on the center. EC organ and tissue donation for related clinical, systemic, legal, and ethical issues. WA 8. Complications. Complications of CPR. Rib fractures, hemothorax, hemopericardium, hemoperitoneum, solid organ injuries, example liver, skin burns, complications of intubation, complications of cardiac arrest. Ischemic cardiomyopathy, acute kidney injury, scent shock, liver, multi-organ dysfunction syndrome, neurological dysfunction. We list the most important complications. The selection is not exhaustive. OIFE, Lose 7. Extracorporeal life support, ECLS. Send extracorporeal CPR, ACPR, uses ECMO for patients in cardiac arrest to support end organ perfusion while underlying causes are treated. ECPR may be beneficial in select patients with cardiac arrest refractory to standard ACLS in specialized centers with experienced providers. 2. A. Ensure scene safety. 1. Rescuer. Cardiac arrest and cardiopulmonary resuscitation, 1/8. Unresponsive adult. 2. Rescuer. 1. Call for help and direct someone to get an AED. 2. Activate EMS. Why? 1. Call for help. 2. Instruct second rescuer to activate EMS and get AED. Pulse present, __6 breathing normal. Monitor until emergency services arrive. Recheck pulse every 2 minutes. Check carotid pulse and breathing simultaneously, do not take 10 SEC, manage airway, begin no pulse, rescue breathing abnormal, 1 breath every 5 to 6 SEC. Pulse present, breathing abnormal J. Asterisk compression depth, 2 to 2.4, 5 to 8 centimeters, start chest compression CPR ratio, 30 compressions asterisk compression rate, 100-120/min asterisk allow full recoiling of the chest CPR ratio, 30:2 asterisk first rescuer, 30 compressions to 2 breaths asterisk minimize interruptions. 1. Stop chest compressions without stopping chest. 2. Turn on AED and attach pads to patient. 3. Restart chest compressions. Compressions, instruct second rescuer to turn on AED and attach pads to patient. Pulse present or clear signs of life. Stop CPR and transfer to acute. When AED is ready and every 2 minutes. Asterisk pause chest compressions asterisk check cardiac rhythm/pulse. I know NME. Care facility. Non-shockable rhythm, i.e., P or AZ's toll. I know shock advised. Shockable rhythm, i.e., VFib or VTach. Pause chest compressions hands off patient deliver shock. Adult basic life support, BLS. Why? Restart chest compressions for 2 minutes. Chest compression technique rate of compressions, 100 to 120 per minute compression depth, 5 to 6 centimeters, 2 to 2.5 inches, give 30 chest compressions followed by 2 rescue breaths, then repeat. Chest compression technique VV. Chest compressions are performed using both hands, one on top of the other, fingers interlaced, which should be centered over the sternum. The arms are kept straight and the provider's body weight is used to deliver rapid, firm compressions to a depth of 5 to 6 centimeters at a rate of 100 to 120 per minute. After each compression, the chest must be allowed to fully recoil before the next compression is delivered to allow adequate venous return and coronary blood supply. Copyright Boss. Eurocardiac arrest and cardiopulmonary resuscitation, 3/8. Rescue breathing technique. Open the airway using the head tilt/chin lift maneuver. Pinch the patient's nose closed. Inhale, then place mouth over the patient's mouth. Breathe into patient's mouth over once while watching for chest rise. Remove the mouth to allow air to escape, then give second breath. Rescue breathing technique VV note, while removing the mouth between rescue breaths to allow air to escape, ensure the airway remains open by maintaining head tilt/chin lift. Copyright Boss. Cardiac arrest and cardiopulmonary resuscitation, 4/8. Basic life support, BLS, pre-all right, e.g. help. An AED. Check responsiveness and call for help. On open the airway and assess breathing, and carotid pulse if drained. With help, ask for 911, call an AED alone, call 911, and get AED if nearby. 30 chest compressions. 2 rescue breaths. Rhythm analysis when AED arrives, then every 2 minutes. Deliver shock if indicated. 8 Immediately restart CPR and continue until professional help arrives or patient shows clear signs of life. Hands /off. C. J. GEAE equals EIMEJ. Basic life support VV. If 2 rescuers are present or help arrives when called, the second rescuer should be asked to make an emergency call and retrieve an AED, if available. If there is only 1 rescuer present and no help arrives when called, some modifications are necessary. Prior to commencing CPR, the rescuer should make the emergency call and, if there is an AED nearby, retrieve it. Copyright Boss. Advanced Cardiac Life Support, 6 Unresponsive Adult I, ACLS, agonal breathing or no pulse or no /respirations 2. A start CPR 4. E administer OO via bag valve mask. E attach defibrillator J. 5. Shockable analyze rhythm non-shockable rhythm as soon as possible rhythm /J. Shockable rhythms non-shockable rhythms. E ventricular fibrillation. E azystole sent pulseless ventricular. E pulseless electrical tachycardia activity /. Administer shock initial dose 120 to 200 J / increases needed __. 3. After second shock. Epinephrine every epinephrine 3 to 5 minutes as soon as possible sent after third shock, then repeat every 3 to 5 minutes / amiodarone or lidocaine. No ROSC shockable rhythm non-shockable rhythm. Resume CPR for 2 minutes then analyze rhythm and check for signs of ROSC. Sent consider advanced airway 4 * obtain 4/IO access sent treat reversible causes concurrently drug dosages XSJ treat reversible causes 5 H's and 5 T's. Signs of ROSC, epinephrine 1 mg 4/IO every 3 to 5 minutes at hypoxia thrombosis, coronary. Amiodarone 300 mg V/IO once, SI of ROSC, smiley face, hypovolemia thrombosis, pulmonary, then 150 mg 4/IO once after 3 to 5 minutes CAI hypo-tension pneumothorax. Lidocaine 1.5 mg/kg, V/IO once, then degree clear signs of life. G. Breathing, hyperkalemia toxins 0.5 to 0.75 mg/kg 4/IO once after 3 to 5 minutes coughing, movement hypothermia 10 periodin, antag, return of pulse/BP hydrogen ion, acidosis, abrupt and sustained increase in LE expiratory CO2 on capnography. GIY return of spontaneous circulation obtain a complete set of vitals, ROSC, and send laboratory studies initiate continuous cardiorespiratory L monitoring J. Consider for emergency cardiac intervention in the presence of STEMI, PET veered e.g. unstable cardiogenic shock at mechanical circulatory support required. A. Admit to ICU for post-resuscitation care. Stabilize the patient and evaluate and manage reversible causes of cardiac arrest. S4. YY optimize airway and breathing. Optimize circulation optimize disability. Secure airway and titrate FiO2 and treat hypotension with 4 fluids. Maintain euglycemia and consider respiratory rate, aiming for vasopressors and /or inotropes. Targeted temperature management aiming for in comatose patients, aiming for SPOs 92 to 98%. Re-emate 65 mm Hg degree PACO, 35 to 45 mm Hg urine output 0.5 mix/here core temperature 32 to 36 degrees Celsius. Advanced Cardiac Life Support, ACLS, A. / anterior lateral anterior posterior. Placement of adhesive electrode pads for defibrillation, electrical cardioversion, or transcutaneous pacing. Left, anterior lateral position. The anterior electrode pad is placed inferior to the right clavicle. The lateral electrode pad is placed over the left 5-6 intercostal space in the anterior axillary or mid-axillary line, which corresponds to the position of the cardiac apex. Right, anterior-posterior position. The anterior electrode pad is placed on the sternum. The posterior electrode pad is placed in the left infrascapular region. The electrode pads should be placed such that the heart lies at the midpoint of the electrical current between the two pads, which maximizes the amount of current that reaches the heart. Copyright emboss. Anterior lateral, anterior posterior. Placement of paddles for defibrillation or electrical cardioversion VV. Left, anterior apical position. The sternal paddle is placed to the right of the sternum, just below the right clavicle in the midclavicular line. The apical paddle is placed over the left 5°-6 intercostal space in the anterior axillary or mid-axillary line, which corresponds to the position of the cardiac apex. Right, anterior-posterior position. The sternal paddle is placed on the midpoint of the sternum. The apical pad is placed in the left infrascapular region. The paddles should be placed such that the heart lies at the midpoint of the electrical current between the two paddles, which maximizes the amount of current that reaches the heart. Copyright emboss. Urocardiac arrest and cardiopulmonary resuscitation, 8/8. Ventricular fibrillation asystole PIA-WV defibrillation possible defibrillation not possible pulseless ventricular tachycardia pulseless electrical activity. Rhythms in cardiopulmonary resuscitation VV copyright emboss. Chest compression technique rate of compressions, 100 to 120 per minute compression depth, 5 to 6 centimeters, 2 to 2.5 inches, give 30 chest compressions followed by 2 rescue breaths, then repeat. Chest compression technique VV. Chest compressions are performed using both hands, one on top of the other, fingers interlaced, which should be centered over the sternum. The arms are kept straight and the provider's body weight is used to deliver rapid, firm compressions to a depth of 5 to 6 centimeters at a rate of 100 to 120 per minute. After each compression, the chest must be allowed to fully recoil before the next compression is delivered to allow adequate venous return and coronary blood supply. Copyright emboss. Urocardiac arrest and cardiopulmonary resuscitation, 2/2. Rescue breathing technique. Open the airway using the head tilt/chin lift maneuver. Pinch the patient's nose closed. Inhale, then place mouth over the patient's mouth. Breathe into patient's mouth over once while watching for chest rise. Remove the mouth to allow air to escape, then give second breath. Rescue breathing technique VV note, while removing the mouth between rescue breaths to allow air to escape, ensure the airway remains open by maintaining head tilt/chin lift. Copyright emboss. Ensure scene safety. 1 rescuer. Cardiac arrest and cardiopulmonary resuscitation, 1/4. Unresponsive adult. 2 rescuer. 1 call for help and direct someone to get an AED. 2. Activate EMS. Why? 1 call for help. 2. Instruct second rescuer to activate EMS and get AED. Pulse present, __6 breathing normal. Monitor until emergency services arrive. Recheck pulse every 2 minutes. Check carotid pulse and breathing simultaneously, do not take 10 SEC, manage airway, begin no pulse, rescue breathing abnormal, 1 breath every 5 to 6 SEC. Pulse present, breathing abnormal J. Asterisk compression depth, 2 to 2.4, 5 to 8 centimeters, start chest compression CPR ratio, 30 compressions asterisk compression rate, 100-120/min * allow full recoiling of the chest CPR ratio, 30:2 * first rescuer, 30 compressions to 2 breaths * minimize interruptions. 1 stop chest compressions without stopping chest. 2. Turn on AED and attach pads to patient. 3. Restart chest compressions. Compressions. Instruct second rescuer to turn on AED and attach pads to patient. Pulse present or clear signs of life. Stop CPR and transfer to acute. When AED is ready and every 2 minutes. * pause chest compressions * check cardiac rhythm / pulse. I know NME. Care facility. Non-shockable rhythm, i.e., P or AZ's toll. I know shock advised. Shockable rhythm, i.e., VFib or VTach. Pause chest compressions hands off patient deliver shock. Adult basic life support, BLS. Why? Restart chest compressions for 2 minutes. Cardiac arrest and cardiopulmonary resuscitation, 2/4. Basic life support, BLS. Check responsiveness and call for help. Open the airway and assess breathing and carotid pulse if trained. With help, ask for 911 call and AED alone, call 911, and get AED if nearby. 30 chest compressions to rescue breaths. Rhythm analysis when AED arrives, then every 2 minutes. Deliver shock if indicated. 8 Immediately restart CPR and continue until professional help arrives or patient shows clear signs of life. Basic life support. All right? And get an AED. \YY. Are you call 911? Hands off. Equals. Eurocardiac arrest and cardiopulmonary resuscitation, 3/4. Recovery position A. \_anterior lateral anterior posterior. Placement of adhesive electrode pads for defibrillation, electrical cardioversion, or transcutaneous pacing. Left, anterior lateral position. The anterior electrode pad is placed inferior to the right clavicle. The lateral electrode pad is placed over the left 5-6 intercostal space in the anterior axillary or mid-axillary line, which corresponds to the position of the cardiac apex. Right, anterior posterior position. The anterior electrode pad is placed on the sternum. The posterior electrode pad is placed in the left infrascapular region. The electrode pads should be placed such that the heart lies at the midpoint of the electrical current between the two pads, which maximizes the amount of current that reaches the heart. Copyright Boss. Advanced cardiac life support, 6 Unresponsive adult ACLS, agonal breathing or no pulse or no /respirations. 2. Start CPR 4. Administer OO via bag valve mask. Attach defibrillator. J. 5. Shockable analyze rhythm non-shockable rhythm as soon as possible rhythm \J. Shockable rhythms non-shockable rhythms. Ventricular fibrillation. EAZ's toll sent pulseless ventricular pulseless electrical tachycardia activity \. Administer shock initial dose, 120 to 200 J, \__ increases needed __. 3. After second shock. Epinephrine every epinephrine 3 to 5 minutes as soon as possible sent after third shock, then repeat every 3 to 5 minutes \__ amiodarone or lidocaine. No ROSC shockable rhythm non-shockable rhythm. Resume CPR for 2 minutes then analyze rhythm and check for signs of ROSC. Sent consider advanced airway 4 * obtain 4/IO access sent treat reversible causes concurrently drug dosages XSJ treat reversible causes, 5 H's and 5 T's. Signs of ROSC, epinephrine, 1 mg 4/IO every 3 to 5 minutes at hypoxia thrombosis, coronary. Amiodarone, 300 mg, V/IO once, SI of ROSC, smiley face, hypovolemia thrombosis, pulmonary, then 150 mg 4/IO once after 3 to 5 minutes CAI hypo-tension pneumothorax. Elidocaine, 1.5 mg/kg, V/IO once, then degree clear signs of life, G, breathing, hyperkalemia toxins 0.5 to 0.75 mg/kg 4/IO once after 3 to 5 minutes coughing, movement hypothermia 10 periodin, ANTAG, return of pulse/BP hydrogen ion, acidosis, abrupt and sustained increase in LE expiratory CO2 on capnography. GIY return of spontaneous circulation obtain a complete set of vitals, ROSC, and send laboratory studies initiate continuous cardiorespiratory L monitoring J. Consider for emergency cardiac intervention in the presence of STEMI, PET veered e.g. unstable cardiogenic shock at mechanical circulatory support required, A. Admit to ICU for post-resuscitation care, stabilize the patient and evaluate and manage reversible causes of cardiac arrest. S4. YY optimize airway and breathing, optimize circulation optimize disability, secure airway and titrate FiO2 and treat hypotension with 4 fluids, maintain euglycemia and consider respiratory rate, aiming for vasopressors, and/or inotropes, targeted temperature management aiming for in comatose patients, aiming for SPOs 92 to 98% re-emate 65 mm Hg degree PACO, 35 to 45 mm Hg urine output 0.5 mg/Here core temperature 32 to 36 degrees Celsius. Advanced cardiac life support, ACLS, A. Eurocardiac arrest and cardiopulmonary resuscitation, 2/7. Ventricular fibrillation azystole PIA WV defibrillation possible defibrillation not possible pulseless ventricular tachycardia pulseless electrical activity. Rhythms in cardiopulmonary resuscitation VV copyright Boss. AMSA, SEMA 1:10 2% 8 o'clock MS SOT 7 Botoy Halo 7 He 7 /Opal S. Courtesy of Jason E. Roediger, CCT, CRAT ENN1 AVR EVA VYVA. RHA WY MACE NL NAN WM. MAVF V3 WV. 6. V6A. Ventricular fibrillation VV. 12 lead ECG, paper speed, 25 mm/s. No discernible P waves, QRS complexes, or T waves. Absence of the normal isoelectric baseline. Chaotic irregular deflections representing disorganized electrical activity in the ventricles with a rate of 375/min can be seen. Diagnosis, ventricular fibrillation. Note that this rhythm results in loss of cardiac output and is fatal unless resuscitation is rapidly commenced. Source, Ventricular Fibrillation by JA 5150, Wikimedia Commons, licensed under CC by SA 3.0. Eurocardiac arrest and cardiopulmonary resuscitation, 4/7. HR, J192 Anaeato AAAAACAI. Monomorphic ventricular tachycardia VV. Single lead ECG, paper speed, 25 mm/s, rate, 192/min regular rhythm, no port T waves are discernible because of the high ventricular rate. QRS complexes are broad, 120 milliseconds, and monomorphic, there is a similar QRS morphology in all beats. These features are characteristic of monomorphic ventricular tachycardia, VT. VT persisting for equals 30 seconds is considered sustained VT, this strip does not show the full 30-second interval. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, Lead to Rhythm Ventricular Tachycardia VTach VT. Created by Glenn Larson. Licensed under public domain. Modifications to original image, text removed. Eurocardiac arrest and cardiopulmonary resuscitation, 5/7. Monomorphic ventricular tachycardia. Polymorphic ventricular tachycardia. Tours aides de points. Comparison of monomorphic and polymorphic ventricular tachycardia, VT, including Tours aides de points VV. Monomorphic VT, QRS morphology is similar throughout, indicating a single arrhythmogenic focus. Polymorphic VT, QRS morphology varies, indicating multiple arrhythmogenic foci. Tours aides de points is a subtype of polymorphic VT occurring in patients with QT prolongation, in which the QRS complexes appear to twist around the isoelectric line. Copyright emboss. _anterior lateral anterior posterior. Placement of adhesive electrode pads for defibrillation, electrical cardioversion, or transcutaneous pacing. Left, anterior lateral position. The anterior electrode pad is placed inferior to the right clavicle. The lateral electrode pad is placed over the left 5-6 intercostal space in the anterior axillary or mid-axillary line, which corresponds to the position of the cardiac apex. Right, anterior posterior position. The anterior electrode pad is placed on the sternum. The posterior electrode pad is placed in the left infrascapular region. The electrode pads should be placed such that the heart lies at the midpoint of the electrical current between the two pads, which maximizes the amount of current that reaches the heart. Copyright emboss. Anterior lateral anterior posterior. Placement of paddles for defibrillation or electrical cardioversion VV. Left, anterior apical position. The sternal paddle is placed to the right of the sternum, just below the right clavicle in the midclavicular line. The apical paddle is placed over the left 5°-6 intercostal space in the anterior axillary or mid-axillary line, which corresponds to the position of the cardiac apex. Right, anterior posterior position. The sternal paddle is placed on the midpoint of the sternum. The apical pad is placed in the left infrascapular region. The paddles should be placed such that the heart lies at the midpoint of the electrical current between the two paddles, which maximizes the amount of current that reaches the heart. Copyright emboss. Cardiac arrest and cardiopulmonary resuscitation, 1/1. Air oxygen mixer, blender. Veno-arterial extracorporeal membrane oxygenation VV. Illustration of peripheral cannulation using the femoral vein and femoral artery. Other access techniques may be used. Deoxygenated blood is removed from the right atrium and returned to the descending aorta after oxygenation in a retrograde direction. If the heart is not beating and there is no residual cardiac output, this retrograde flow will reach as far back as the closed aortic valve, and the extracorporeal membrane oxygenation, ECMO, system will provide all of the patient's circulation. If there is remaining physiological output from the left ventricle, the two flows meet and create a mixing cloud of poorly oxygenated blood from the native circulation and well-oxygenated blood from the ECMO circuit. The mixing cloud depicted here is in the aortic arch, where red and blue arrows meet. It may, however, be located anywhere between the aortic valve and the ECMO cannula tip and shift depending on changes in left ventricular output and ECMO blood flow. The location of the mixing cloud influences the oxygen content of the blood reaching the various aortic branches. In this example, while the renal arteries receive well-oxygenated blood from the ECMO circuit, red arrows, the carotid and subclavian arteries receive more poorly oxygenated blood from the mixing cloud, purple arrows. Supraventricular tachycardia. Supraventricular tachycardias, SVTs, are a group of tachyarrhythmias arising from abnormalities in pacemaker activity and/or conduction involving myocytes of the atria and/or AV node. Types of SVT include atrioventricular nodal reentrant tachycardia, often right, approximate 2/3 of cases, atrioventricular reciprocating tachycardia, AVRT, focal atrial tachycardia, FAT, multifocal atrial tachycardia, MAT, and junctional tachycardia. Right and AVRT are caused by abnormal conduction circuits that form an unending loop of conduction referred to as reentry. These reentry circuits can occur between parallel pathways within the AV node, as in right, or between the AV node and an accessory pathway of atrioventricular conduction, as in AVRT. Atrial tachycardias, FAT and MAT, and junctional tachycardias are usually the result of abnormal or ectopic pacemaker activity and do not involve reentry. The most common congenital accessory pathway, bundle of Kent, is seen in Wolff-Parkinson-White WPW syndrome and can cause ventricular pre-excitation, in which supraventricular impulses bypass the AV node and are abnormally conducted to the ventricles, leading to a characteristic pre-excitation pattern on ECG and a specific subset of pre-excited tachyarrhythmias. SVTs have similar clinical features, typically paroxysms of tachycardia with dizziness, dyspnea, chest pain, or syncope, that may be self-limiting or progress to hemodynamic instability and sudden cardiac death. Common diagnostic steps include obtaining the patient's history and a 12-lead ECG to identify the type of SVT. The paroxysmal nature of SVTs means that continuous recording with a Holter monitor is often needed to confirm the diagnosis. In some cases, invasive electrophysiological studies, EP studies, may also be indicated. Management of SVT should be tailored to the patient. Most hemodynamically unstable patients are treated with emergency cardioversion, while patients with acute SVT episodes that are hemodynamically stable may benefit from vagal maneuvers and/or antiarrhythmic medication, typically intravenous, depending on the underlying rhythm. Long-term management may involve antiarrhythmic medication or curative catheter ablation. The following are discussed in detail separately: management of tachycardia, atrial fibrillation with rapid ventricular response and atrial flutter. OO and definitions. Tachycardias. Sent paroxysmal tachycardia, an arrhythmia with an abrupt onset and termination that can last from seconds to days. Example of right, IU sent supraventricular tachycardia, SVT, copyright a tachycardia originating in the following, 22I3. Equals sinus node equals AV node equals atrial myocardium equals bundle of is above the bifurcation copyright includes, equals reentrant tachycardias, example of right, AVRT equals atrial tachycardias, focal at, multifocal at, AFib, atrial flutter equals inappropriate sinus tachycardia equals junctional tachycardia o paroxysmal SVT, PSVT. Equals any SVT with a narrow QRS complex and an abrupt onset equals most commonly caused by AV nodal reentry conduction abnormalities. Reentry. A mechanism that causes an impulse in the heart, which would normally die out, to return via conduction circuit to re-excite the tissue, leading to an extra beat, or, if it continues, an ongoing tachyarrhythmia. IISE examples of reentrant tachycardias include right and AVRT. Aberrant conduction L7. Sent abnormal conduction of a myocardial impulse due to, example a bundle branch block, conduction delay, or, according to some definitions, an accessory pathway results in a wide QRS complex, as the depolarization of the ventricle happens more slowly, from myocyte to myocyte, rather than through rapidly conducting Purkinje fibers. Sent SVT with aberrant conduction can have a very similar appearance to ventricular tachycardia. Pre-excitation. Eventricular pre-excitation, the premature activation of the ventricles by an accessory pathway. Accessory pathway, an abnormal electrical connection outside of the AV node that allows for the propagation of impulses between the myocardium of the atrium and the ventricle, usually congenital. Example the bundle of Kent, see Wolff-Parkinson-White syndrome, but also rarely acquired 2-cent pre-excitation syndrome, the combination of ventricular pre-excitation and associated tachyarrhythmias. Example AVRT, atrial flutter, atrial fibrillation, focal atrial tachycardia. WPW syndrome is the most common example sent pre-excitation pattern, the typical ECG appearance of ventricular pre-excitation due to abnormal conduction and depolarization of the ventricles. Back collapse. Find text outline. Overview. Treat unstable SVTs, except for MAT and junctional tachycardia, with electrical cardioversion. 3. If there is doubt about the supraventricular origin of a wide complex tachycardia, treat it as ventricular tachycardia. Type of SVT. Right 1. Orthodromic AVRT. Antidromic AVRT. Focal AT. Multifocal AT. AFib with RVR. Atrial flutter. WPW syndrome. Junctional tachycardia. Description. Asterisk caused by two alternative electrical pathways within the AV node, forming a reentry circuit. Asterisk caused by a reentry circuit that conducts antigrade through the AV node and retrograde through an accessory pathway. Asterisk caused by a reentry circuit that conducts antigrade through an accessory pathway and retrograde through the AV node. Asterisk arises from a localized atrial focus outside of the SA node. Stent caused by multiple atrial pacemaker foci. Asterisk often associated with chronic lung disease and right atrial enlargement. Asterisk caused by uncoordinated electrical activity in the atria, example fibrillatory waves. Multiple possible underlying causes of AFib. Asterisk caused by rein-trans circuits within atrial tissue. Etiologies are the same as the causes of AFib. Asterisk a congenital condition characterized by intermittent tachycardias involving an accessory pathway, bundle of Kent, and ventricular pre-excitation. Caused by abnormal automaticity of myocytes in the AV node and bundle of his asterisk types. Paroxysmal junctional tachycardia, PJT, accelerated AV junctional rhythm, AFJR. Overview of SVTs, ALS. Distinguishing ECG features. HR, 150-220/minute rhythm, regular P wave, rarely visible. See ECG findings in right for details. HR, 120-250/minute rhythm, regular narrow QRS complex. P wave follows QRS complex. HR, 120-250/minute rhythm, regular wide QRS complex shortened PR interval. See ECG findings in AVRT for details. HR, 100-250/minute rhythm, regular P wave, constant morphology, may be obscured by QRS complex isoelectric baseline between P waves. QRS complex, usually narrow, may be wide in aberrant conduction. See ECG findings in FAD for details. HR, 100-200/minute rhythm, irregular P wave, 2-3, distinct morphologies. Prairie interval, variable QRS complex, usually narrow, may be wide in aberrant conduction. See ECG findings in MAD for details. HR, 100-110/minute rhythm, irregular P waves, indiscernible QRS complex, usually narrow, may be wide in aberrant conduction. HR, 75-150/minute, depends on ratio of conduction, rhythm, typically regular, may be regularly irregular or irregularly irregular sawtooth P waves. QRS complex, usually narrow, may be wide in aberrant conduction. Sinus rhythm with pre-excitation pattern delta wave wide QRS complex. Findings of associated arrhythmias, example ECG findings in AVRT, AFib with WPW. See ECG findings in WPW for details. HR, PJT 100/minute, AFJR 60/100/minute rhythm, regular P wave, inverted in lead 2 short PR interval narrow QRS complex C ECG findings in junctional tachycardia for details. V. N collapse. Acute of stable. Vagal maneuvers adenosine. Vagal maneuvers adenosine. Established diagnosis, AV nodal blockers are safe. Uncertain diagnosis, avoid AV nodal blockers. See treatment of AVRT for details. Vagal maneuvers uncertain diagnosis, adenosine established diagnosis, CCBs or beta blockers wide complex tachycardia, avoid AV nodal blockers. Treat the underlying cause. Metoprolol or verapamil. Long-term management options. Catheter ablation AV nodal blockers. See treatment of right for details. Asterisk catheter ablation pharmacotherapy for AVRT. Catheter ablation asterisk pharmacotherapy pacemaker implantation asterisk C management of FAD for details. Wide complex tachycardia, avoid AV nodal blockers. See treatment of MAD for details. Acute management of rapid AFib and AFLUT is the same. Options include acute rate control and rhythm control. AFib with WPW, avoid AV nodal blockers, treat with cardioversion. See management of AFib with RVR for details. Regular NCT, i.e., orthodromic AVRT vagal maneuvers, adenosine NEWCT, regular or irregular avoid AV nodal blockers, treat with cardioversion. See treatment of WPW for details. Beta blockers and CCBs. Long-term rate control or rhythm control. Treat the underlying condition. Consider catheter ablation for AFLUT. See treatment of AFib with RVR for details. Catheter ablation antiarrhythmics. See long-term management of WPW for details. Treat underlying cause, example digoxin toxicity, catheter ablation for select patients. See treatment of junctional tachycardia for details. Q. Find text. O. Outline. Epidemiology 2. Cent prevalence of SVT, 2.3 per 1,000. Cent incidence of PSVT, 36 per 100,000 per year. Sex, $at, 2:1. Cent risk factors. Copyright underlying structural heart disease. O family history of SVT or sudden cardiac death. Copyright use of certain medications or illicit drugs. 19. Epidemiological data refers to the U.S., unless otherwise specified. 7-6. Clinical features. Palpitations, fatigue, chest pain or discomfort, dyspnea, dizziness or presyncope. Syncope, uncommon, occurs more frequently in older adults. Diaphoresis. Additional features seen more commonly in right/2I11. Copyright feeling of neck pounding/shirt flapping, thought to be due to canon A waves. Copyright urinary urgency and polyuria. Symptom onset and resolution are typically abrupt, in contrast to sinus tachycardia, in which onset and resolution are more gradual. Sudden cardiac death, rare, 121. 6. Signs of unstable tachycardia due to SVT include acute pulmonary edema, hypotension, severe chest pain, and altered mental status. 7-AE. Diagnostics. Once the diagnosis is confirmed by ECG, do not delay acute management of SVT for additional investigations. Initial diagnostics. 11. ECG. A 12-lead ECG should be performed in every patient with suspected SVT. A copyright typical features during an episode include, regular rhythm, may be irregular in MAT or atrial fibrillation rate 100/minute, typically exceeds 150/minute. 2. Narrow QRS complex. Copyright initial imaging modality of choice. Copyright potential findings include, underlying structural or ischemic heart disease heart failure in prolonged tachycardia atrial thrombus, rare. OOE. Differential diagnoses. Although differentiating between types of SVT can be challenging and may require EP studies to confirm the diagnosis, some ECG features may help to differentiate diagnoses. Equals, AOO. Back collapse fine text outline. Plus sinus tachycardia, most common differential, often secondary to physiologic stress 15 cent other narrow complex tachycardias, NCTC also differential diagnosis of SVT. Other wide complex tachycardias, WCTC also SVT with aberrancy versus VTach. Copyright patients with SVT symptoms are frequently misdiagnosed with anxiety or panic disorders. Rule out paroxysmal tachycardia before making a psychiatric diagnosis to avoid anchoring bias. The differential diagnoses listed here are not exhaustive. Why and management. Acute management of SVT 228. The underlying type of SVT is often unclear at presentation. A definitive diagnosis is not required to begin acute management of tachycardia following ACLS algorithms. Initiate continuous cardiac monitoring and ECG recording for all patients. Keep a defibrillator at the bedside in case rhythm and/or hemodynamics change, example new VFib. Pulseless patients. Sent start CPR. Sent defibrillate any WCT, i.e., possible VTach, otherwise, treat as P. Patients with unstable tachycardia with pulse. Perform synchronized electrical cardioversion for most SVTs. Sent cardioversion will likely be ineffective for multifocal and junctional tachycardia. Stable patients. Empiric management depends on QRS width and rhythm. Sent SVT of unclear origin, see management of undifferentiated SVT. Sent regular NCT, example of right, orthodromic AVRT, focal at, copyright typically includes vagal maneuvers and adenosine OC management of stable regular NCT. Sent irregular NCT, example multifocal at, AFib, copyright can include rate control, rhythm control, or management of the underlying cause. Copyright C management of stable irregular NCT. Sent WCT, example SVT with aberrancy, antidromic AVRT, AFib with WPW, O usually treated with cardioversion EAV nodal blockers are best avoided. OC management of stable WCT. O. Avoid using AV nodal blockers to treat wide complex tachycardias, as they may precipitate VFib. R6LF17. Vagal maneuvers. Sent definition, a set of actions performed to decrease the heart rate through physical stimulation of the vagus nerve. Sent physiology, slows the conduction through the AV node, negative homotopy, and may terminate the arrhythmia. Sent clinical application an important first step in acute management of most SVTs. Copyright avoid in ventricular pre-excitation, due to an accessory pathway, with any of the following underlying tachyarrhythmias, atrial flutter, atrial fibrillation, focal atrial tachycardia, and MAT. Valsalva maneuver. Sent definition, forceful exhalation against a closed airway. Sent technique, 4 phases. Copyright phase 1, start strain, and phase 2, continued strain. 1 intrathoracic pressure venous return / ventricular preload cardiac output. O phase 3, release of strain, and phase 4, recovery phase. Intrathoracic pressure after load T stroke volume 7 cardiac output. Sent applications. Copyright treatment of supraventricular tachycardia, example of right, O evaluate conditions of the heart. Back collapse fine text outline. Sent applications. Copyright treatment of supraventricular tachycardia, example of right, O evaluate conditions of the heart equals augments heart sounds on physical exam, example earlier click in mitral valve prolapse and louder murmur in hypertrophic obstructive cardiomyopathy, decreases heart sounds intensity, most valve stenosis or regurgitation murmurs. Copyright test for hernia or varicocele, increased intra-abdominal pressure bulging, Copyright diagnosis of urinary stress incontinence, urine leakage during the maneuver, O measure to normalize middle ear pressure, example in diving. Scent contraindications, include recent myocardial infarction, aortic stenosis, and glaucoma. 8. Modified Valsalva maneuver 18. Scent patient sits in a semi-recumbent position. Scent blows into a 10 ml syringe for 15 seconds, moving the plunger up achieves a strain of 40 mm Hg. 19. Afterwards the patient is laid supine and the legs are passively elevated to 45 degrees for 15 seconds. Scent return to the semi-recumbent position for 45 seconds before reassessing rhythm. Carotid sinus massage 2 degrees. Listen first to ensure there are no carotid brutes. If present, select another vagal maneuver. 121. Apply steady pressure at the level of the carotid bifurcation on one side for 10 to 15 seconds. If there is no response, the process can be repeated using the contralateral carotid sinus. Carotid sinus massage stimulates the baroreceptors. Stimulate CN9, specifically the branch of the glossopharyngeal nerve to the carotid sinus, nerve impulse transmission to the medulla, nucleus tractus solitarius, efferent signals from the medulla to the myocardium via the vagus nerve, parasympathetic supply, AVN conduction, heart rate, contractility, and vasodilation, blood pressure, may cause presyncope or syncope, termination of arrhythmia. Diving reflex. Scent traditionally involves immersing the head in cold water, which is uncomfortable for most patients, plus can be limited to applying a bag of ice water to the face, particularly the forehead and nasal area, for 10 seconds. 1, 22. Do not simultaneously apply bilateral carotid artery pressure because this can impede cerebral blood flow. Pharmacotherapy. See management of undifferentiated SVT for a general algorithm. Scent definitive pharmacotherapy depends on the underlying rhythm. Copyright C treatment of Right. OC treatment of AVRT. OC treatment of WPW. Copyright C treatment of focal at. OC treatment of MAD. OC management of AFib with RVR. OC treatment of junctional tachycardia. Catheter ablation. Scent description: a radiofrequency or cryothermal energy is applied via a cardiac catheter to eliminate aberrant pathways or impulses from arrhythmogenic foci. O usually performed in conjunction with an EP study. Indications to copyright curative therapy in Right, AVRT with concealed pathway, or drug refractory at copyright symptomatic patients who want to avoid long-term drug therapy, especially younger patients, degree asymptomatic patients with special lifestyle considerations, example pilots. OCE. Atrioventricular nodal reentrant tachycardia. Definition. A tachyarrhythmia caused by a dysfunctional AV node that contains two electrical pathways, which form a reentry circuit. Pathophysiology. Scent: the AV node contains two electrical pathways, one fast and one slow. The electrical impulse circles around the AV node. Within both pathways a continuous circuit conducts impulses to the ventricles. Tachycardia. Approximate 90% of cases are due to anterograde conduction across the slow conducting pathway and retrograde conduction in the fast pathway, although the reverse is possible. Back collapse. Find text outline. ECG findings in Right 24125. ECG may be normal between episodes of tachycardia. Findings may be indistinguishable from those of orthodromic AVRT and include: scent heart rate typically 150-220/minute, scent typically narrow QRS complexes. A wide QRS complex may be seen if there is aberrant conduction. Irregular rhythm * P wave is typically not visible, it falls in or is buried in the QRS complex. 5. Treatment of Right. Acute management. Scent unstable tachycardia with a pulse, electrical cardioversion. Scent stable with narrow QRS complex, see management of stable regular NCT. Copyright first step, vagal maneuvers. Copyright if SVT persists, Intravenous medical therapy first line, adenosine, if no contraindications to adenosine present, equals other options, calcium channel blockers, example verapamil, diltiazem, or beta blockers, example metoprolol, sent stable with wide QRS complex, suspected aberrant conduction. C. Management of stable WCT. Copyright established diagnosis of right, AV nodal blocking agents are generally safe. 126 Copyright uncertain diagnosis of right, avoid AV nodal blocking agents. Long-term management. Sent infrequent and mild episodes, may be managed with self-guided vagal maneuvers. Plus first line, percutaneous catheter ablation of the slow pathway. 2I27 second line, pharmacological therapy. 21 Copyright daily medication options equals beta blockers, example propranolol equals verapamil equals diltiazem. Copyright pill in the pocket regimens, off-label, 28. VU. Rushat. Atrioventricular reciprocating tachycardia. Definition. A tachyarrhythmia caused by an accessory pathway that creates a renin-trans circuit with the AV node plus Wolff-Parkinson-White syndrome is a common cause of AVRT, but they are not synonymous. 111. Pathophysiology 5 pounds, 111L29. Sent orthodromic AVRT, most common, 90 to 95%. 30 Copyright antegrade conduction, atrium ventricle, through AV node, narrow QRS complex, retrograde conduction, ventricle atrium, through accessory pathway. Copyright can occur with a concealed or manifest pathway. Copyright on rare occasions, occurs almost incessantly as a result of a concealed, posteroceptal pathway, permanent junctional reciprocating tachycardia, PJRT, 231 plus antidromic AVRT, rare, 5-10%, $321 E. Antegrade conduction, atrium ventricle, through accessory pathway, retrograde conduction, ventricle atrium, through AV node O wide QRS complex, as ventricular depolarization happens slowly from myocyte to myocyte rather than through the rapid His-Purkinje system. Copyright only occurs with a manifest pathway. And AVRT is caused by an accessory pathway, whereas in right there are two functional pathways within the AV node. ECG findings. Back collapse. Find text outline. ECG findings. ECG findings in AVRT 33 IL1 11134. Heart rate 150-250/minute regular rhythm narrow QRS complex EAD eals *P wave typically follows QRS complex. Because the AP is conducting in a retrograde direction, there is no visible delta wave during the tachyarrhythmia. * can be indistinguishable from right. Sent heart rate 150-250/minute sent regular rhythm antidromic AVRT sent wide QRS complex, similar in appearance to ventricular tachycardia, pre-excited focal atrial tachycardia, and pre-excited atrial flutter, shortened PR interval *. The morphology of the QRS complex means that the delta wave is frequently not visible during the tachyarrhythmia. Treatment of AVRT. Acute episodes. Unstable tachycardia with a pulse, electrical cardioversion sent stable orthodromic AVRT, C. Management of stable regular NCT. First step, vagal maneuvers. If SVT persists, intravenous medical therapy first line, adenosine, if there are no contraindications to adenosine, equals other options, calcium channel blockers, example verapamil, diltiazem, or beta blockers, example metoprolol, sent stable antidromic AVRT, wide QRS complex. C. Management of stable WCT. Copyright established diagnosis of AVRT, AV nodal blocking agents are safe. Copyright uncertain diagnosis of AVRT, avoid AV nodal blocking agents. Long-term management 2. Sent first line, catheter ablation. Pharmacotherapy for AVRT, For patients who are not candidates for ablation or who prefer medication, treatment depends on whether a pre-excitation pattern is seen on ECG. Options include sotalol, flecainide, and propafenone. 2-cent alternative, consider amiodarone if no other treatments are effective or if all are contraindicated. VA and Wolff-Parkinson-White syndrome. Definitions. Wolff-Parkinson-White syndrome, WPW, a congenital condition characterized by intermittent tachycardias and signs of ventricular pre-excitation on ECG, both of which arise from an accessory pathway known as the bundle of Kent Wolff-Parkinson-White pattern, characteristic signs of ventricular pre-excitation on ECG with no evidence of arrhythmia and no reported symptoms. 38 Pathophysiology. A congenital accessory pathway, the bundle of Kent, connects the atria and ventricles, bypassing the AV node and leading to ventricular pre-excitation. May be asymptomatic, WPW pattern, or associated with arrhythmias, WPW syndrome, including 36 OAVRT, most common, 80%, copyright atrial fibrillation, 15 to 35%, incidence increases with age, atrial flutter, 5%. Epidemiology. Symptoms typically develop at 20 to 40 years of age. 36 ECG findings in WPW. While in sinus rhythm, a pre-excitation pattern may be present. 9 Copyright short PR interval OECG delta wave, a slurred upstroke at the start of the QRS complex, secondary to pre-excitation plus a widened QRS asterisk can show any of the arrhythmias associated with WPWL. Back collapse fine text outline. Asterisk can show any of the arrhythmias associated with WPWL. Copyright see ECG findings in AVRT. OCWPW with atrial fibrillation. Treatment of WPW1. Acute episodes. Unstable tachycardia with a pulse, electrical cardioversion. Stable, assess underlying rhythm. Copyright regular NCT, i.e., orthodromic AVRT vagal maneuvers, adenosine, C. Management of stable regular NCT. Copyright WCT, irregular, example underlying AFib or multifocal at, or regular, underlying AFLUT or focal at, 1, 8, avoid AV nodal blocking agents and vagal maneuvers, may precipitate VTach or VFib, 1 rhythm control measures, i.e., cardioversion or 4-procainamide, are the safest treatment option. C. Management of stable WCT and management of pre-excited AFib. Avoid AV nodal blocking agents and vagal maneuvers for the following pre-excited tachycardias, AFib, AFLUT, focal at, and MAT. Long-term management of WPW 240. Management of WPW pattern and WPW syndrome depends on underlying risk factors and patient preference. Risk stratification in WPW syndrome. 41. Risk stratification is determined by a cardiologist based on clinical, ECG, and electrophysiological parameters. Concerning clinical features: syncope, copyright associated atrial fibrillation, atrial flutter, or atrial tachycardia, aborted sudden cardiac death. Dynamic ECG testing, example ambulatory Holter monitoring or exercise stress testing to assess for evidence of intermittency or loss of pre-excitation. 42. EP studies. High-risk patients. Catheter ablation of the accessory pathway should be offered to all patients. 2. Low-risk patients. 2, 7. Asymptomatic, usually no treatment required. Symptomatic. First line, catheter ablation. Copyright second line, example ablation contraindicated or declined. Long-term antiarrhythmics. OOCES. Focal atrial tachycardia. Definition. Plus focal atrial tachycardia, FAD, Focal at a supraventricular tachycardia that arises from a localized atrial focus outside of the SA node 2 cent atrial tachycardia, at an umbrella term for focal atrial tachycardia and multifocal atrial tachycardia, MAT, that is often used synonymously with focal atrial tachycardia etiology 15. Cent idiopathic, most common cent chronic conditions, hypertension, heart disease, cardiomyopathy cent acute conditions, myocardial infarction, infection, alcohol poisoning cent drug toxicity copyright digoxin, most common, copyright theophylline copyright cocaine pathophysiology, 431 I 441. Back collapse fine text outline. Pathophysiology / 431 / 44. Plus possible mechanisms 45 copyright triggered activity, a result of early after depolarizations, EAD, or delayed after depolarization, DAD, copyright microentry, slow conduction at discrete regions of fibrotic cardiac tissue copyright enhanced automaticity, acceleration of a normal automatic pacemaker 144 cent key features copyright originates outside of the SA node O abrupt onset copyright can be sustained or non-sustained O worsened by adrenergic activity. ECG findings in focal at 21L461 plus heart rate 100-250/minute 1 4E1 cent regular rhythm cent can have 1:1 or 2:1 AV conduction wave copyright typically visible in 2:1 at copyright may be hidden by the QRS complex or T wave in 1:1 at 4 copyright the morphology depends on the site of origin but remains constant. Copyright an isoelectric baseline is present between P waves. Cent QRS complex, morphology does not vary O narrow complex. Most common EO-wide QRS complex may be present in SVT with aberrant conduction. 6. An isoelectric baseline between P waves can help distinguish focal at from atrial flutter. Treatment of focal at 21. Acute episodes. Episodes of focal atrial tachycardia are most commonly self-limiting and asymptomatic, in which case they do not require treatment. Cent unstable tachycardia with a pulse, electrical cardioversion cent stable copyright narrow QRS complex first step, vagal maneuvers, equals if SVT persists, intravenous medical therapy equals first line if there are no contraindications to adenosine and diagnosis of focal at is not established, adenosine first line if diagnosis of focal at is established, calcium channel blockers, example verapamil, diltiazem, or beta blockers, example metoprolol, equals C. Management of undifferentiated SVT 4. Details. Copyright wide QRS complex, suspected aberrant conduction, equals pre-excited focal at ruled out, AV nodal blocking agents are generally safe. Equals pre-excited focal at possible, avoid AV nodal blocking agents. Equals C. Stable, wide complex tachycardia for details. Cent all patients, identify and treat acute reversible underlying conditions, see etiology. Avoid AV nodal blockers in patients with pre-excited focal atrial tachycardia, example due to WPW, because they can trigger ventricular arrhythmias. Long-term management. Cent catheter ablation, for symptomatic patients who are candidates, example refractory at, younger age, focal atrial tachycardia-induced cardiomyopathy, or those who prefer it as an alternative to pharmacotherapy 47148 pharmacotherapy copyright beta blockers, example metoprolol copyright CCBs, verapamil or diltiazem PPL degree P implantation, consider for patients with refractory symptoms after unsuccessful invasive and medical therapy. Cent surgery, example left atrial isolation less common since the advancement of catheter ablation 49 cent other O management of underlying conditions, see etiology, copyright anticoagulation, not indicated in the absence of coexisting arrhythmia. Back collapse fine text outline. Multifocal atrial tachycardia. Definition. Sent an irregular SVT featuring equals 3 morphologies of P waves. 2. Etiology 50L51. Severe underlying conditions, example heart failure and pulmonary diseases, such as COPD or pneumonia, plus drugs, example theophylline, isoproterenol, 521 cent electrolyte abnormalities, example hypokalemia, hypomagnesemia, cent other, hypoxia, hypercapnia, acidosis, dysautonomia. Pathophysiology 53. Cent multifocal origin of pacemaker activity * mechanism remains unclear, 50 * often associated with right atrial enlargement. ECG findings in MAT 5 degrees. Cent heart rate 100-200/minute cent irregular rhythm P waves copyright 3 or more varying morphologies O separated by an isoelectric baseline variable PR interval cent QRS complex, morphology does not vary O narrow QRS complex, most common O wide QRS complex may be present in aberrant conduction may progress to atrial fibrillation. Do not confuse MAT with atrial fibrillation. In a fib, there are no distinct or organized P waves, whereas in MAT there are distinct P waves with varying morphologies. Unlike in atrial flutter, in MAT there are distinct isoelectric intervals between P waves. Het EEGL net yon VWJ me Kyurt Z eder RGTTE hat DDDDTDE, ITT. Treatment of multifocal atrial tachycardia /2I111 I54. Treatment of MAT is challenging and specialists should be involved early. Patients often have severe underlying conditions and rhythm control and electrical cardioversion are not effective. For clinically oriented management algorithms for patients with tachycardia, see Management of Tachycardia. Cent first-line treatment, management of underlying causes 55O manage exacerbations of chronic diseases, see etiology above. Copyright correct reversible conditions, example hypoxemia, acidosis, electrolyte abnormalities. See potassium replacement and magnesium replacement. Discontinue potential offending medications. Copyright for magnesium may be helpful even in patients with normal magnesium levels. 71 plus rate control, copyright beta blockers, example metoprolol copyright calcium channel blockers, verapamil AV node radiofrequency ablation, consider in refractory MAT. Registered avoid AV nodal blockers in patients with pre-excited MAT, example due to WPW, because of the risk of ventricular arrhythmias. Avoid electrical cardioversion and antiarrhythmic drugs, example procainamide, lidocaine, phenytoin, as they are not effective in treating MAT. 254. CE. Junctional tachycardia. Definition. Plus a tachyarrhythmia caused by abnormal automaticity of myocytes in the AV node and bundle of his 5, there are two possible presentations. Back collapse fine text outline. Junctional tachycardia. Definition. A tachyarrhythmia caused by abnormal automaticity of myocytes in the AV node and bundle of his scent. There are two possible presentations. Paroxysmal junctional tachycardia, PJT sudden onset, rapid tachycardia, heart rate 100/minute, copyright accelerated AV junctional rhythm, non-paroxysmal junctional tachycardia gradual onset, and termination, rhythm, which can cause a mild tachycardia, heart rate 60-100/minute, etiology 21. Paroxysmal junctional tachycardia most commonly seen in infants with congenital heart disease. Copyright following myocardial infarction. Copyright transiently during slow pathway ablation in right plus accelerated AV junctional rhythm. 1 Copyright digoxin toxicity. Copyright catecholamine use 15 cent L degree COPD O hypokalemia. Pathophysiology 2111. Caused by an ectopic focus of abnormal automaticity in the AV node or the proximal bundle of his ECG findings in junctional tachycardia 211,571. While the rate varies between paroxysmal junctional tachycardia and accelerated AV junctional rhythm, the ECG appearance is otherwise similar. Cent heart rate copyright PJT, 100/minute copyright accelerated AV junctional rhythm, typically 60-100/minute 1 * narrow QRS complex 1 regular, occasionally may be irregular. Cent P wave is inverted in lead 2 and can be hidden within the QRS complex copyright immediately before the QRS complex O immediately after the QRS complex E short PR interval. Treatment of junctional tachycardia 2. These recommendations are for confirmed junctional tachycardia. For clinically oriented management algorithms for patients with tachycardia, see Management of Tachycardia. Cent acute episodes, intravenous pharmacotherapy O beta blockers, example metoprolol, copyright non-dihydropyridine CCBs, example verapamil, long-term management to copyright accelerated AV junctional rhythm, identify and treat the underlying cause, example digoxin toxicity. Copyright paroxysmal junctional tachycardia, medical therapy, example non-dihydropyridine CCBs, beta blockers, copyright catheter ablation, consider in selected patients with PUT. VA Veliotes. Tips and links. Sources. Last updated August 7, 2023. Back collapse fine text outline. Supraventricular tachycardia, 1/2. 1 2 3. 1. Normal impulse conduction no excitation normal impulse conduction, sinus rhythm, sinus rhythm. 4 5 6. RDE, X, IE, I. 1 I 1 1 1 1 1 1 OI 1 1 1 1 1 5 1 1 4 HII tissue with H11I prolonged refractory period 4 AYA 4 scar tissue TSAE/para 4 QCento, Orital, 2 LL refractory tissue premature impulse, circular impulse conduction excitation of example from an extrasystole surrounding cardiac tissue. Cardiac reentry mechanism V. This illustration depicts the formation of a reentry circuit in ventricular tissue. However, similar principles apply to the formation of reentry circuits in other cardiac tissues. Left, reentry requires the presence of a non-excitable anatomical obstruction, here, ventricular scar tissue, and of two areas of tissue with mismatched conduction properties, here, healthy ventricular myocardium and a damaged area around the scar with a prolonged refractory period. Right, development of a reentry tachyarrhythmia 1. Normal impulse conduction of sinus rhythm 2. Pause between impulses, healthy myocardium excitable again but damaged tissue remains refractory, red, 3. Normal impulse conduction of sinus rhythm 4. A premature impulse occurs in the pause shortly after the previous impulse, example from a ventricular extrasystole. The wave of excitation is blocked on one side of the scar tissue by an area of refractory tissue but can pass on the other side. Plus. Supraventricular tachycardia, 1/2. 1 2 3. I. And /EEE normal impulse conduction no excitation normal impulse conduction, sinus rhythm, sinus rhythm. 4 5 6. SSA. 17U. UJ1 tissue with IN prolonged refractory period AI scar tissue /Ken Lee refractory tissue premature impulse, circular impulse conduction excitation of example from an extrasystole surrounding cardiac tissue. Cardiac reentry mechanism. Left, reentry requires the presence of a non-excitable anatomical obstruction, here, ventricular scar tissue, and of two areas of tissue with mismatched conduction properties, here, healthy ventricular myocardium and a damaged area around the scar with a prolonged refractory period. Right, development of a reentry tachyarrhythmia 1. Normal impulse conduction of sinus rhythm 2. Pause between impulses, Healthy myocardium excitable again but damaged tissue remains refractory, red. 3. Normal impulse conduction of sinus rhythm 4. A premature impulse occurs in the pause shortly after the previous impulse, example from a ventricular extrasystole. The wave of excitation is blocked on one side of the scar tissue by an area of refractory tissue but can pass on the other side. 5. By the time the wave of excitation has passed the scar tissue, the previously refractory tissue is now excitable again, leading to circular impulse conduction. 6. Circular impulse conduction continues and excites the surrounding myocardium, leading to a reentry tachycardia. Dual AV nodal physiology. Atria. SA node slow pathway fast pathway, short, long refractory pausa period. AV node dash asterisk. Incoming current. RKG impulse from slow pathway conducted is blocked via fast pathway ventricles. At atrial premature 5 rat beat, APB, Q, GB, retrograde activation at, fast pathway of atria out of refractory _period 4. Pathway YSNN APB, NY conducts equals backslash via slow equals pathway WY slash backslash. Retrograde BA conduction to atria via fast pathway reentry circuit is created. Pathophysiology of typical atrioventricular nodal reentrant tachycardia, right, VV. Right is a tachyarrhythmia caused by a dysfunctional AV node with two electrical pathways, one fast with a long refractory period and one slow with a short refractory period, dual AV nodal physiology. During normal sinus rhythm, the conduction occurs via the fast pathway, and the incoming current from the slow pathway is extinguished, top right image. Typical right is triggered by an atrial premature beat, APB. 1. An APB arrives at the AV node during the fast pathway's refractory period. The impulse is, therefore, conducted through the slow pathway, which is out of its refractory period. 2. When the impulse reaches the distal junction of the two pathways, the fast pathway has recovered its excitability and the impulse can travel up retrograde. 3. The impulse reaches the atria, leading to an almost simultaneous depolarization of the atria and ventricles. The current re-enters the slow pathway. 4. A re-entry circuit is created with anterograde conduction across the slow conducting pathway and retrograde conduction in Tha fact nathwia ratioiltina in cetanade 10 hunardia. Dual AV nodal physiology. Atria. SA knee slow pathway fast pathway, short, long refractory piece period, AV node dash asterisk. Incoming current impulse from slow pathway conducted is blocked via fast pathway ventricles. At atrial premature 5 rat beat, APB, Q, GB, retrograde activation at, fast pathway of atria out of refractory _period 4. Pathway YSN and APBY conducts /equals backslash via slow equals PITHWA backslash /Y backslash S asterisk YXY retrograde big conduction to atria via fast pathway reentry circuit is created. Pathophysiology of typical atrioventricular nodal reentrant tachycardia, right, VV. Occurs via the fast pathway, and the incoming current from the slow pathway is extinguished, top right image. Typical right is triggered by an atrial premature beat, APB. 1. An APB arrives at the AV node during the fast pathway's refractory period. The impulse is, therefore, conducted through the slow pathway, which is out of its refractory period. 2. When the impulse reaches the distal junction of the two pathways, the fast pathway has recovered its excitability and the impulse can travel up retrograde. 3. The impulse reaches the atria, leading to an almost simultaneous depolarization of the atria and ventricles. The current re-enters the slow pathway. 4. A re-entry circuit is created with anterograde conduction across the slow conducting pathway and retrograde conduction in the fast pathway resulting in sustained tachycardia. Copyright Boss. Supraventricular tachycardias, SVTs, QRS narrow QRS. E. Ventricular rate? No. No HE of. T. Vagal maneuvers yes, R. Key rhythm converts, variable AVI, 23 different P-wave AA Gimqui and TE, to sinus morphologies, ENE, full waves identical ectoplow varying PR intervals equals atrial flutter, HPRP waves. Atrial flutter multifocal atrial IEEE and atrial fibrillation, AR, 250 to 350 BPM, AR, 150 to 250 BPM, AEAVR tachycardia variable AV block AR $50-450 BPM, loss of isoelectric baseline, orthodromic, baseline, between P waves. Tachycardia SVTs with aberrant PPIG with wide QRS-JEIGA, multifocal atrial flutter / atrial fibrillation EAVRT ventricular with aberrant, atrial 5E pacemaker aberrant variable AV block conduction with aberrant conduction tachycardia, E.9, AE pre-excitation tachycardia, VT, TE to points, oleate, BBB with aberrant, 8B or H, BBB or pre-excitation, or with BBB, tachycardia, PMT. 23 different P-wave II morphologies, nay or yes, varying PR intervals nay. Pacemaker present no, and telemetered low intracardiac, electrogram indicating PMT. Yes VT, example Brugada, yes or unclear criteria present. Of unclear. Irregular rhythm H regular rhythm. QRS equals 120 milliseconds wide QRS wide complex tachycardias. Tachycardia differentials VV. Copyright Boss. Euro supraventricular tachycardia, 2/13. Cardiacs V4.37.7 July 7, 2022, 1842 1T, midnight to 0:05:25 mm/s10 mm/mv. Overlay. Atrioventricular nodal reentrant tachycardia, often right, VV. 12 lead ECG, paper speed, 25 mm/s, regular rhythm, heart rate 190/min. Normal cardiac axis, RS in leads and AVF, narrow QRS complexes. Equals supraventricular tachycardia, 3/13. Orthodromic AVRT antidromic AVRT. Accessory SA node plus at --VF pari ni AV node TE. 0 AIAL. No delta wave. /J. OM. Orthodromic and antidromic AVRT. Copyright PAOLL allele copyright A equals retrograde P waves. E narrow QRS complex * wide ORS complex EP wave typically follows QRS complex E delta and P waves may not be visible. VV atrioventricular reciprocating tachycardia, AVRT, can occur when an accessory pathway allows the formation of a reentrant circuit. AVRT is classified as orthodromic, 90 to 95%, conduction through AV node is atrium ventricle, or antidromic, rare, conduction through AV node is ventricle atrium, which can be differentiated by their ECG features. Note that the ECG of antidromic AVRT is very difficult to distinguish from that of ventricular tachycardia, VT. Copyright Boss. Supraventricular tachycardia, 4/13. Inside of Aachen bands, IICAAAF4 by OSIAF1 EA RIEMA NA. Foot, Rentajos Bet WEAEP Bed KKESAF7, IESEA Autogate B5 Pete F4 Carat DFT 25 Hz AC 60 Auto 6x2+3. Overlay. Non-sustained focal atrial tachycardia VV. 2 periods of sinus rhythm, varying between 79-85/min, black interval lines, alternating with 2 periods of tachycardia, 137/min, dashed black interval lines, P-wave morphology and axis during tachycardia, red overlay, are different from those during sinus rhythm, green overlay. During the periods of tachycardia, the P-waves remain constant, indicating a single ectopic focus. 1:1 AV conduction, QRS morphology remains normal throughout. Normal QRS axis, RS in an AVF, an isoelectric baseline is present. Courtesy of Jason E. Roediger, CCT, CRAD. AEA. VY. Non-an AFAR equals HPBL VSE. E. V6A. Overlay. Multifocal atrial tachycardia VV. 12 lead ECG, paper speed, 25 mm/s, irregular tachycardia with both atrial and ventricular rates of approximate 120-200/min, see examples of longer and shorter RR intervals in the overlay. Left axis deviation, RS in, SR in AVF. P waves with different morphologies, including normal, biphasic, and inverted waves, in the same lead, arrows. P waves return to the isoelectric line, thus there is no atrial flutter/fibrillation. PP, PR, RR, and QT intervals are variable. QRS length and morphology are largely normal. No signs of ischemia, however, interpretability is limited. In summary, irregular tachycardia with variable P-wave morphology, consistent with the diagnosis of multifocal atrial tachycardia. Source: Multifocal Atrial Tachycardia, Matt by J 5150, Wikimedia Commons, licensed under CC by SA 3.0. Euro supraventricular tachycardia, 6/13. Nargud Helage Cardiosharta int Opera 7, has /AIE. AMI NT Nels Ja TIDCC. LJI. 33-1 Li, I. IIHILI TTII, JIIHHIIFIIIH /JDN LAN AIZXIHJ high FN if SHEK vacate DSA fu PPK FS Mara LASAEI or MM REIM SA. 4 leg IAI 7 *1, IAM /I5 AEII, FIESAI FETN FFII Arial B Oris 1 H POC Cape ESFCEEY Odd ERWA. Akal Burrogar ENEAACV Wink WW Wag Era Eshias OS Anam Saints WAWP Nia EG ETEAE. RR, RR, RR LAR RRRB RRRR, I, TTTTTT1JE, Cell EA Feats ESEAETBs AA1BT I My Sarah 2 We, Recall I PASA III /SASSEA SAIRSGTEGN. SDGRE Pari GEGE Bears EESGAUSAG INANA OALD. B. PCSAGA FIA AENAS Pray IGIM All EAD Pause Ano AFSLR of Ed / JYVY Fed NSEE Pains AOD. EAE4 Eofen Tima Yes 6 AJ Capletuan SI Via NEN VA /ETA VYFJBAA. 4 IHT /WRBSSDES FOS EAECEE1 Best TJIEEGS AFA EATE BIS here, IAT Pari 11 AAWAD. PTAARAATUAT APA C all MNEY LAC. AEAESEEAE Pair EEREETOELEE1 4 AFIIJ /I FUA 2 Intent Re NOE Re Keith NEAA 8 Way VS Hair near EA Han CAE Way SIA, IESPEI. 20 Mir 2004 2 hours 1 minute and 15 seconds ends 2 Daug WI, Ain't I Drift Sis Insight 010820 Hz Famal W226. EE, Enafi EE Estot Ela and EE Endo EESA per SSU EASNT SEERE at EEEEEEE get ESEEEELNEEEE. Overlay. Atrial fibrillation with rapid ventricular response VV. 6 lead ECG, paper speed 25 mm/s. Heart rate, 135/min irregular RR intervals, examples indicated by black overlay, normal axis, absent P waves coarse fibrillatory waves, F waves, examples indicated by red overlay, can be seen between the QRS complexes. These are characterized by low amplitude, high frequency, and irregular morphology, and should not be confused with P waves or flutter waves. The absence of P waves with irregular RR intervals and an elevated heart rate indicates atrial fibrillation with rapid ventricular response. Source: Copyright IMPP. Supraventricular tachycardia, 7/13. Irregularly irreg. Overlay. Atrial fibrillation with rapid ventricular response VV. 12 lead ECG, paper speed, 25 mm/s, irregular rhythm average ventricular rate is 144/min, 24 QRS complexes can be seen on the 10-second rhythm strip, no discernible P waves narrow QRS complexes normal cardiac axis. These findings are characteristic of atrial fibrillation with rapid ventricular response. Canis ursa aeakst watees sapsaris at fsserssrssarrwyca. Euro supraventricular tachycardia, 8/13. HR, 127 QRS, 94 ms Street, 80 milliseconds Pax, minus 117 PD, 98 milliseconds QT, 310 milliseconds TD, 136 milliseconds QRS AX, 2 PR, 154 milliseconds QTC FRA, 391 milliseconds TX, 32 QRS TX, 3D14. 1 WZ0s AA. YYLL pipe EYUPEPEE Uruni. Ave SL tant IILIATSII is he. Cardiacs V4.37.24-11-2020 midnight to 005 25 mm/s 10 mm/mv. Atrial flutter with 2:1 atrioventricular, AV, block VV. 12 lead ECG, paper speed, 25 mm/s, regular rhythm, atrial rate of 250/min and ventricular rate of 125/min, normal axis, RS in and AVF, sawtooth P wave morphology, flutter/F waves, best seen in IL, AVF. These findings indicate atrial flutter with 2:1 AV block. Our great thanks to Thomas Waldiak, MD, for kindly providing this case. Euro supraventricular tachycardia, 9/13. HR, 82 QRS, 104 ms Street, 86 milliseconds PX, minus 90 PD, 184 milliseconds QT, 490 milliseconds TD, 300 milliseconds QRS AX, minus 12 PR, 214 milliseconds QTC FRA, 531 milliseconds TX, 36 QRS TX, 3D13. Cardiacs V4.37.724-11-2020 15-26 1T, 001 to 006 25 mm/s 10 mm/mv. Atrial flutter with 3:1 atrioventricular, AV, block VV. 12 lead ECG, paper speed, 25 mm/s, regular rhythm, atrial rate of 250/min and ventricular rate of 83/min, normal axis, RS in and in IL, sawtooth P wave morphology, flutter/F waves, best seen in IL, AVF. These findings are indicative of atrial flutter with 3:1 AV block. Our great thanks to Thomas Waldiak, MD, for kindly providing this case. Supraventricular tachycardia, 10/13. Y. Delta. Delta wave ECG schematic, paper speed, 25 mm/s, top, normal ECG findings bottom, slurred upstroke, i.e., delta wave, of the QRS complex is visible. The delta wave is a sign of Wolff-Parkinson-White syndrome. Copyright Boss. Supraventricular tachycardia, 11/13. HR, 68 QRS, 126 ms Street, 100 milliseconds px, 64 PD, 88 milliseconds QT, 400 milliseconds TD, 174 milliseconds QRS AX, 67 PR, 112 milliseconds QTC FRA, 418 milliseconds TX, U4, QRS TX, 3D 116. Cardiacs V4.37.7 May 2nd, 2021, 13:081 T, midnight to 0:05 25 mm/s 10 mm/mv. Overlay. Wolff-Parkinson-White syndrome VV. 12 lead ECG, paper speed, 25 mm/s, regular sinus rhythm rate 68/min normal axis, RS in leads and AVF, short PR interval, 112 milliseconds, wide QRS complexes, 126 milliseconds, with delta waves, the slurred initial portion of the QRS complex, zoom box, a short PR interval and widened QRS complexes with delta waves are the characteristic ECG findings of Wolff-Parkinson-White, WPW, syndrome. If seen in asymptomatic patients with no evidence of arrhythmia, this constellation of findings is referred to as the WPW pattern. Our great thanks to Thomas Waldiak, MD, for kindly providing this case. Normal impulse transmission pre-excitation in WPW syndrome. X bundle of Kent SA node pre-excitation AV node. PR interval shortened PR interval QRS duration widened QRS. Wolff-Parkinson-White, WPW, syndrome and pattern VV. Conduction pathways and characteristic ECG findings in normal impulse transmission and in WPW syndrome. Note that the condition is referred to as WPW syndrome only if the characteristic ECG findings are present and the patient is also symptomatic or there is evidence of arrhythmia. If the characteristic ECG findings are present without these additional features, the condition is referred to as WPW pattern. Left, normal impulse transmission and normal ECG findings PR interval 120 to 200 milliseconds, QRS duration. Supraventricular tachycardia, 13/13. Copyright. Overlay Y. Junctional tachycardia VV. 12 lead ECG, paper speed, 25 mm/s, regular rhythm, heart rate, 130/min, P waves immediately follow the QRS complexes, examples indicated with green arrowheads, and are inverted in IL, AVF, and V4VE, retrograde P waves, examples indicated with red arrowheads. Cardiac axis borderline normal/right axis deviation, isoelectric in, RS in AVF, narrow QRS complexes, ADMS, persistent S wave. Dual AV nodal physiology. Atria. SA knee slow pathway fast pathway, short, long refractory piece period, 1 avenue node ***. Incoming current impulse from slow pathway conducted is blocked via fast pathway ventricles. At atrial premature 5 rat beat, APB, Q, GB, retrograde activation at, fast pathway of atria out of refractory _period 4. Pathway YS and an APBY conduct /equals / via slow equals pth y /y /s *YXY retrograde big conduction to atria via fast pathway reentry circuit is created. Pathophysiology of typical atrioventricular nodal reentrant tachycardia, often right, VV. Often right is a tachyarrhythmia caused by a dysfunctional AV node with two electrical pathways, one fast with a long refractory period and one slow with a short refractory period, dual AV nodal physiology. During normal sinus rhythm, the conduction occurs via the fast pathway, and the incoming current from the slow pathway is extinguished, top right image. Typical often right is triggered by an atrial premature beat, APB. 1. An APB arrives at the AV node during the fast pathway's refractory period. The impulse is, therefore, conducted through the slow pathway, which is out of its refractory period. 2. When the impulse reaches the distal junction of the two pathways, the fast pathway has recovered its excitability and the impulse can travel up retrograde. 3. The impulse reaches the atria, leading to an almost simultaneous depolarization of the atria and ventricles. The current re-enters the slow pathway. 4. A re-entry circuit is created with anterograde conduction across the slow conducting pathway and retrograde conduction in the fast pathway result in sustained tachycardia. Supraventricular tachycardia, 2/5. Cardiacs V4.37.7 July 7, 2022, 1842 1T, midnight to 0:05:25 mm/s10 mm/mv. Overlay. Atrioventricular nodal reentrant tachycardia, often right, VV. 12 lead ECG, paper speed, 25 mm/s, regular rhythm, heart rate 190/min. Normal cardiac axis, RS in leads and AVF, narrow QRS complexes. Supraventricular tachycardia, 3/5. Fascia e succi surrec onc nanaunet. RRRRRRRRALUA. UTIC is CAOOAEEOOBs. A. Copyright. Overlay. Atrioventricular nodal reentry tachycardia, often right, VV. 6 lead ECG, paper speed 25 mm/s, showing often right being terminated with adenosine left of dashed line, often right before onset of adenosine effect, typical slow fast subtype, heart rate approximate 160/min, regular rhythm, regular RR intervals, narrow QRS complexes. P waves are visible after the QRS complexes, examples indicated by arrows and P, short RP interval of 40 milliseconds right of dashed line, transient irregular rhythm following termination of often right by adenosine source, D. Often right ECG, Cardio Networks eCpedia, by Cardio Networks, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Atrioventricular nodal reentrant tachycardia, often right, VV. 12 lead ECG, paper speed, 25 mm/s. Regular rhythm, heart rate approximate 188/min, normal cardiac axis, narrow QRS complexes. Source, Figure 1, in Atrioventricular nodal reentrant tachycardia triggered by marijuana use, a case report and review of the literature by P.T. Karyayana, A. Jayarangayah, O. Urivic et.al., American Journal of Medical Case Reports, licensed under CC by 4.0. Modifications, arrows removed. Supraventricular tachycardia, 5/5. J. Abiaes, SSIIRIESAs, a 3-pi-k ad fospum k zapan at ELA insecte pon canes la eat satan ene fisern aessnsae. 3 yi 2 yen. MTASTBL scar NEA EAA equals SE ax array HI1. TIT of AT72 FTG LTHTIFPOCVV SSAESSECE OA as EEVT FA EEEEI. T. Afra SN7 at BAWNWSTW FAC as HNCAM Bay, LSHKEIBALEAYATEIIT1 yen YIY11 TT if 11. Device, 55,692 speed, 25 mm/SEC limb, 10 mn/MV chest, 10 mm/MV LF 60 0.15 to 100 Hz FIOB CLP. Atrioventricular nodal reentrant tachycardia, right, VV. 12 lead ECG, paper speed, 25 mm/s. Regular rhythm, heart rate approximate 130/min. Left axis deviation, QRS complexes are positive in, negative in AVF and I. Narrow QRS complexes. This ECG shows the characteristic features of right, a regular, narrow complex tachycardia without visible P waves. The rate however is typically higher, 150-220/min. Source, EKG of right 030315 by Laniaki Rubicon, Wikimedia Commons, licensed under CC by SA 4.0. Supraventricular tachycardia, 1/1. Orthodromic AVRT antidromic AVRT. Accessory SA node plus at --VF Parini AV node TE. 0 IAL. No delta wave. /J. OM. Orthodromic and antidromic AVRT. Copyright PAOLL allele copyright A == retrograde P waves. Narrow QRS complex * wide ORS complex EP wave typically follows QRS complex E delta and P waves may not be visible. VV atrioventricular reciprocating tachycardia, AVRT, can occur when an accessory pathway allows the formation of a reentrant circuit. AVRT is classified as orthodromic, 90 to 95%, conduction through AV node is atrium ventricle, or antidromic, rare, conduction through AV node is ventricle atrium, which can be differentiated by their ECG features. Note that the ECG of antidromic AVRT is very difficult to distinguish from that of ventricular tachycardia, VT. Copyright emboss. Normal impulse transmission pre-excitation in WPW syndrome. X bundle of Kent SA node pre-excitation AV node. PR interval shortened PR interval QRS duration widened QRS. Wolff-Parkinson-White, WPW, syndrome and pattern VV. Conduction pathways and characteristic ECG findings in normal impulse transmission and in WPW syndrome. Note that the condition is referred to as WPW syndrome only if the characteristic ECG findings are present and the patient is also symptomatic or there is evidence of arrhythmia. If the characteristic ECG findings are present without these additional features, the condition is referred to as WPW pattern. Left, normal impulse transmission and normal ECG findings PR interval 120 to 200 milliseconds, QRS duration. Supraventricular tachycardia, 4/5. Wolff-Parkinson-White, WPW, syndrome with atrial fibrillation, 1/2, VV. 12 lead ECG, paper speed, 25 mm/s, of a patient presenting with palpitations. Irregular rhythm rate 185/min normal axis, RS in leads and AVF, no P waves visible, wide, polymorphic QRS complexes. Atrial fibrillation is a common complication of WPW syndrome, resulting in an irregular, wide complex tachycardia with polymorphic QRS complexes. The patient was treated with 4-procainamide and converted to sinus rhythm, revealing the characteristic ECG features of WPW syndrome. See repeat ECG 2/2. Source, Fig 1, in, Wolff-Parkinson-White syndrome, electrocardiogram by Minor B, Patton J, Chandwani C, J. Tem, licensed under CC by 4.0. Copyright Overlay. Wolff-Parkinson-White, WPW, syndrome after conversion from atrial fibrillation, 2 halves, VV. Repeat 12-lead ECG, paper speed, 25 mm/s, of a patient who initially presented with an irregular wide complex tachycardia, C1 half, after treatment with 4-procainamide. Regular sinus rhythm rate 75/min normal axis, RS in leads and AVF, PR interval 120 ms, low end of normal range, wide QRS complexes, 160 ms, with delta waves, the slurred initial upstroke of the QRS complex, examples indicated by arrows. Procainamide terminated the atrial fibrillation seen in this patient's initial ECG, 1 half, and revealed the characteristic ECG findings of Wolff-Parkinson-White, WPW, syndrome seen here, widened QRS complexes with delta waves and a short PR interval. Supraventricular tachycardia, 1/1. 1 Rima NA. Foot, Rentajos bet WEAEP bed KKESAF7, IJAS Amesa B5 Pete F4 Grag EE at DFT 25 Hz AC 60 Auto 6x2 plus 3. Overlay. Non-sustained focal atrial tachycardia VV. 2 periods of sinus rhythm, varying between 79-85/min, black interval lines, alternating with 2 periods of tachycardia, 137/min, dashed black interval lines, P-wave morphology and axis during tachycardia, red overlay, are different from those during sinus rhythm, green overlay. During the periods of tachycardia, the P-waves remain constant, indicating a single ectopic focus. 1:1 AV conduction, QRS morphology remains normal throughout. Normal QRS axis, RS in an AVF, an isoelectric baseline is present. Courtesy of Jason E. Roediger, CCT, CRAD. AEA. VY. Non-an AFAR equals HPBL AVSE. E. V6A. Overlay. Multifocal atrial tachycardia VV. 12-lead ECG, paper speed, 25 mm/s, irregular tachycardia with both atrial and ventricular rates of approximate 120-200/min, see examples of longer and shorter RR intervals in the overlay. Left axis deviation, RS in, SR in AVF. P waves with different morphologies, including normal, biphasic, and inverted waves, in the same lead, arrows. P waves return to the isoelectric line, thus there is no atrial flutter/fibrillation. PP, PR, RR, and QT intervals are variable. QRS length and morphology are largely normal. No signs of ischemia, however, interpretability is limited. In summary, irregular tachycardia with variable P-wave morphology, consistent with the diagnosis of multifocal atrial tachycardia. Source, Multifocal Atrial Tachycardia, Matt by JA 5150, Wikimedia Commons, licensed under CC by SA 3.0. Supraventricular tachycardia, 1/1. Copyright. Overlay Y. Junctional tachycardia VV. 12-lead ECG, paper speed, 25 mm/s, regular rhythm, heart rate, 130/min, P waves immediately follow the QRS complexes, examples indicated with green arrowheads, and are inverted in IL, AVF, and V4VE, retrograde P waves, examples indicated with red arrowheads. Cardiac axis borderline normal/right axis deviation, isoelectric in, RS in AVF, narrow QRS complexes, 80 ms, persistent S wave. For long QT syndrome. Long QT syndrome, LQTS, is a congenital or acquired heart condition in which the QT interval, i.e., ventricular depolarization and repolarization, is prolonged. Most patients with LQTS are asymptomatic, but some present with seizures, syncope, or even life-threatening arrhythmias and sudden death. Treatment depends on the underlying cause. Beta blockers and implantable cardioverter defibrillator, ICD, insertion are commonly used for congenital LQTS, whereas treatment of the underlying cause, drug, electrolyte abnormality, etc., is the first-line therapy for acquired LQTS. WA. CE. Etiology. A prolonged QT interval may be congenital or acquired. Congenital LQTS. Congenital LQTS arises from mutations in genes that code for ion channels within myocytes, example KCNE1 gene, located on chromosome 11p that encodes potassium channels in the heart and inner ear. These mutations all cause ventricular action potentials to be prolonged, resulting in a lengthened QT interval on ECG. 1 plus LATS type 1-4. Most common type of congenital LQTS degree loss of function mutation on the KCNQ1 gene located on chromosome 11p, defective slow delayed rectifier voltage gated potassium channel affected repolarization phase 3O subtypes. Jervell and Lang-Nielsen syndrome falls, associated with congenital deafness autosomal recessive associated with ventricular tachyarrhythmias. Romano-Ward syndrome, no associated deafness autosomal dominant associated with ventricular tachyarrhythmias. Acquired LQTS copyright I7 ILC 9 LL10. Drug-induced LQTS, usually substances that block potassium outflow during the rapid repolarization phase 11 copyright antiarrhythmics, 121. Class law, example quinidine, disopyramide, procainamide, class ill, example sotalol, uncommonly, amiodarone. Degree antibiotics, example macrolides, fluoroquinolones, antihistamines, example diphenhydramine, antidepressants, most tricyclic antidepressants and tetracyclic antidepressants, some SSRIs, lithium, antipsychotics, example haloperidol, ziprasidone, anticonvulsants, example phosphonatoin, felbamate, antiemetics, ondansetron, antifungals, example azoles, anti-Parkinson medications opioids protease inhibitors. Degree electrolyte imbalances, hypokalemia, hypomagnesemia, hypocalcemia plus acute CNS insult, ischemic stroke or intracranial hemorrhage 1, SLL14LE endocrine disorders, hypothyroidism plus nutritional deficiencies, severe vitamin D deficiency, uncommon, 1, 151L16L. BNB compared to other class 3 antiarrhythmics, amiodarone uncommonly causes torsades de pointes. FO. Fe, Co. Clinical features. Often asymptomatic, especially if the QT interval is only minutely prolonged. Some patients present with O palpitations, O dizziness, O syncope. Copyright cardiac arrest. Back collapse. Fine text outline. OO. Sore. Clinical features. Often asymptomatic, especially if the QT interval is only minutely prolonged. Some patients present with O palpitations, degree dizziness, O syncope, O cardiac arrest. GY. ES. Diagnostics. Diagnosis of LQTS can be difficult because a slightly prolonged QT interval can be a normal variant, i.e., not congenital LQTS, and some patients with LQTS do not have a prolonged QT interval. The primary finding in LQTS is a long QT interval corrected for heart rate, QTC, interval. O males, 440 milliseconds. O females, 460 milliseconds. Other diagnostic criteria take patient history and ECG findings into account. Genetic testing confirms the diagnosis of LQTS. AOFOS. Treatment. Sent both congenital and acquired LQTS. Copyright: avoid activities that stress the heart. Copyright: avoid cold temperatures, example swimming, diving, skiing. Congenital LQTS. O first line, beta blockers, example propranolol. O left cardiac sympathetic denervation, stelectomy. Patients not responsive to beta blockers. Copyright: high-risk patients, recurrent syncope despite medical therapy, survival of cardiac arrest. Implantable cardioverter defibrillator, ICD, sent acquired LQTS, treat cause, remove offending drug, fix electrolyte imbalances, etc. And all treatment modalities aim to reduce the risk and severity of cardiac events. Your notes. Shared note. Complications. Sent ventricular tachycardia, torsade de pointes, sent ventricular fibrillation, sent asystole, sudden cardiac death. We list the most important complications. The selection is not exhaustive. OOFOT. Sources. Last updated December 1, 2022. Back collapse. Fine text outline. Device, speed, 25 mm/sec limb, 10 mm/mv equals chest, 10.0 mm/nvs 0.15 to 100 az 100 bcl lad. Prolonged QT interval, long QT syndrome. 12 lead ECG, paper speed, 25 mm/s. Regular ectopic atrial rhythm, negative P waves in 2 and AVF, normally positive, positive P waves in AVR, normally negative, and V1, normally biphasic, heart rate of approximate 75/min, normal cardiac axis, normal PR interval, approximate 120 milliseconds, normal QRS duration, approximate 80 milliseconds, prolonged QT interval, QTC approximate 580 milliseconds, ventricular extrasystole seen in leads to ill. Source, Figure 1, in, long QT syndrome with torsades de pointes managed considering financial constraints faced by the patient by Patel R., Agarwal S., Athwal PSS, Randhawa, Kalan S., Curious, licensed under CC by 4.0.